Okay. I think we got everyone. All right. Welcome, everyone. Thank you for being here. Our seventh, believe it or not, our seventh meeting together. We first convened a year ago, and it's hard to believe. We have lots to cover today, so I'm going to dive right in. I'm going to, as usual, start with the technology moment, just to remind everyone of how to use the technology and what our expectations are of workgroup members and observers. So bear with me while I share my screen. All right, thumbs up that you can see a screen that says Zoom Etiquette workgroup members. Is that right? Yep, all right, good. So as a reminder, I have two different instructions, for one set for our workgroup members, one set for our guests. So if you are a work group member, I'm sure you know this drill now, but just a reminder, your mute and unmute button and video buttons are in the lower left corner. Please, 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 if you can, keep your video on. If you're a workgroup member, it really helps us with facilitation. Plus, we love to see your faces, and it also makes it just easier to collaborate. But keep your mic muted. When you speak, when it's your turn to speak, one of us will click on a button, and you'll get a little notification that says to unmute your mic, and then you can go click on that button in the lower left corner of your screen to unmute your mic. A reminder that we use raising our hand to speak so that we can minimize talking over each other. So the way you find that is you click on your participants button in the bottom center of your screen. It opens a new window, and there you click on the blue raise hand button. We'll lower it for you after we call on you. If you struggle with that, don't worry. We've kind of made an informal rule that you can also wave your hand at us, and we'll try to catch you there too. Couple more things to note. If you want to be able to see all of the workgroup members, I recommend that you go up in the upper right corner and click on gallery view, and that will put everyone's faces on the screen for you. And finally, because of the large number of people participating, we do disable the chat function. You are able to send a chat to the host, but we're not doing the large group chat. Okay, and then for our members of the public, welcome. Thank you as ever for your dedication and participating in our meeting today. We really appreciate your attendance. I'm going to ask all members of the public, so non-workgroup members and non-project team members, to please turn your video off. And this is not because we don't want to see your faces, but because with the number of people in the room, we need to have some way of distinguishing between who's on the workgroup meeting and who's on the workgroup rather, and who's in the public. So if you could please turn your video off for the meeting, that would be much appreciated. When it is time to make public comment, we have 12 people signed up to make public comment today. Then when your name is called, please do turn your video camera on so we can see you while you're making your comment. That is the one time we ask you to have your video camera on. Again, you can use that same gallery view in the upper right corner of your screen to see as many workgroup members as possible. And the chat function is disabled except if you have a message for our host. If you're having any kind of trouble seeing something, that's a good opportunity to send a message to the host. We're going to just, we were normally shifting to our fearless chair, Sue Birch, to give a welcome, but she was called into an emergency cabinet meeting. So we're going to do a little reshuffling. She's going to be here around 1:30, and we'll do a little reshuffling and have her do her welcome when she arrives. For now, what I'd like to do is just take a few moments to review our agenda. Before we do that, though, I'm going to just stop share because we have a workgroup member who joined us a little while back, and I did not see him in our past meeting, so I apologize that I have not yet given him an opportunity to introduce himself to you. But Chris, let's unmute you. I'd like to introduce Chris Bandoli, the Executive Director of the Association of the Washington Healthcare Plans. And Chris, could you just say a few words to introduce yourself to our group? Oh, it looks like you're still on mute there, Chris. That's, New York Liz, can you help us out here? Do you know what's going on?
Can he try one more time to unmute himself? He should be able to do so now.
Okay, let's see if you do it. Oh, darn, I'm sorry, Chris. Liz, what do you, New York Liz, do you think Chris should maybe log off and log on again? Do you think that might help?
It looks like he's unmuted.
I know. I'm sorry, Chris, that's a great welcome we're giving you, not letting you talk.
His computer could be on mute, and that is the reason why we can't hear him also.
No, he's shaking his head. All right, well, you know what, Chris, I will try to come back to you in a little bit so we can give you an opportunity to speak. I'm sorry for the technical challenges. I'll move on and then we'll circle back and see if we can make it work with your mic. I'm going to go back then to our agenda here. All right, so for today's meeting, we have several objectives. First and foremost is to hear public comment on universal health care. As with our last meeting, we've moved that up to the top of our meeting, so we'll start with that. We're going to just spend a few minutes, and Sue's going to speak to this, just to clarify and right-size all of our expectations for the final product from this work group, just because we're getting in the home stretch here, and so we want to make sure that it's really clear what's coming. We have a kind of surprise opportunity here to hear from Jane Beyer today, a brief overview of an example of how universal health care was achieved in Washington State with universal coverage of children. She's just going to spend a few minutes walking us through the steps and timeline to get to that, you know, in the midst of a recession and other challenges. Then, as promised, we're going to review, discuss, and understand the outcomes from the actuarial analyses and answer the questions from our optimi so they can finalize the models and the data can be used in workgroup decision making. Another chunk of our meeting after our stretch break is going to be to discuss and confirm the end state, the goals that we're trying to achieve with universal health care, and then finally spend just a few minutes discussing and confirming any feedback from you on the report outline. And then, of course, as always, confirming action items and next steps and adjourning at 4 o'clock. So this is the full agenda here. We've done, as I said, a little shuffling, so we're going to move Sue's welcome to after the public comment. There will be a stretch break at 2:35. I just made it 5 minutes today. I hope that's okay for everybody, but we have a lot to get through. So I cut it back from 10 minutes today. The breakout group discussions will be after the stretch break, and this is discussing our end goals, and then we'll wrap up at 4, as I said. Quickly, just walk you through where we've been and where we're going. September, so over a year ago, was when we first convened, affirmed our workgroup charter, and level set around universal healthcare and different models for delivering that. In December, for those of you who can remember that far back, we did work together to understand the problems with the current system and do our root cause analysis. In February was when we worked together to develop assessment criteria by which we consider the universal healthcare models. We had to cancel the April meeting due to the pandemic, but we regrouped in June and got together to discuss and refine 3 draft models for universal healthcare. We assessed those models using our agreed upon qualitative criteria in August and also got a status update on our actuarial analyses. We got to hear the first bit of information, and I say bit with air quotes because I know it was a lot, in September around the outcomes from the actuarial analyses, and also did some dive into some of the implementation challenges that we need to consider as we move forward with thinking about what's next for universal health care and implementing it. Today, we're here to continue discussing the outcomes of the actuarial analyses and also discuss and refine goals for universal health care, and of course, refine the outline for the final report, which our project team is drafting. We're getting together in 3 weeks, and that's when we're going to really roll up our sleeves and discuss and identify recommendations for the final report. And then there'll be a break for a bit while the project team drafts the report, and then you get it and review it. And we will all come back together in December to review your feedback and make some final adjustments to the report. So that is where we've been and where we're going. I'm going to now take us to our public comment process so we can dive right into that. These are the rules for public comment. All of our commenters received these rules prior to our meeting, so they're familiar with it. Today, because we had 12 people sign up, we're going to stick with the 2-minute time limit, and that's going to be strictly enforced as ever. I'm going to call on you in the order in which you signed up, as we always do. Please, when you come up, you'll see the timer on your screen. Please do, out of respect and consideration for the other people making comments, stick to that time limit. Let's see, if for any reason we're not able to get to all 12 people today, please do remember that there's an opportunity to provide written comments via email, and you can access the email address for that on the HCA website. And we do always ask our commenters to provide a copy of their written notes, because that does help us and help our work group members. And our work group members see all of the comments, so not just the ones that are provided here, but they also receive the written ones in advance of our meetings. So please know that all of those comments are taken the same way. I'm going to show you the list of people in the order. We have, as I said, 12 people making comment today. And so this is the order. What I'm going to do, as I typically do, is I'm going to call 3 names at a time. The first name is going to be the next person up. And when you hear the other 2 names, please be ready to go. And Mia from HCA is going to be looking for you and sending you a request to unmute so that you can unmute your mic. Again, please do also put on your video camera if you can, if you have the bandwidth at your location and you have the technology. It really does help us to be able to see your face. Okay, I think with that, I'm going to put the timer on the screen. Just bear with me a moment here. All right, so here's our 2-minute timer. And again, the names of our commenters, we're going to start with Larry Cole, followed by Elizabeth Woolley, followed by Kevin Wren. And so Larry, when you're ready to go, please start by stating your name, and I'll start the timer.
I'm Larry Cole, a member of North Seattle Progressives and Healthcare as a Human Right. As a retired licensed mental health counselor, I follow mental health issues. In 2019, legislation improving the mental health system in Washington was proposed on dozens of topics. This was great, but one area saw little action. In 2020, mental health is a news topic. COVID increased rates of mental illness, domestic violence, and revealed racial disparities in care. There was a Times op-ed by Marcus Green, When Racism and Stigma of Mental Illness Collide, on the catastrophe of a Black man with a psychotic break in downtown Seattle, with his frantic mother trying to decide what to do. Decriminalize Seattle and Equity Now talk about transferring funds from police to, among other things, mental health responders. Again, one topic got short shrift. In both years, I've heard little talk about people paying for mental health care. Mental health crisis services are great, but there may be fewer crises if we offered treatment first. I worked with older adults and disabled people and saw them maintain stability over years, despite a decades-long history of chronic mental illness, if they got regular help. In last month's summary, mental health was mentioned once on the next to last slide, with no description of services and no cost-benefit data. Mental health practices vary with a broad range of costs. Session time and frequency and modality, individuals versus groups, etc., drive costs, and each option has its own data on effectiveness. I would like to encourage this group to provide details about the types of mental health support being considered, as well as the costs associated with each. Effectiveness data on this would be as helpful here as evaluating the effectiveness of expensive new medical treatments. Thank you.
Thank you, Larry. And I apologize, I had a little technical difficulty with our timer there, but I think I've got us set up now, so I'll have it going for our next speaker. So next up is Elizabeth Woolley, followed by Kevin Wren, followed by David McClanahan. And just a quick reminder, if you are part of the work group and you are able, please do turn your video camera on. If you are a member of the public and you are not speaking during public comment, please turn your video camera off. Okay, Elizabeth, when you're ready, you can go ahead and introduce yourself and I'll start the timer.
Hi, I'm Lizzie Woolley. think I'm going now. Sorry, I've never done this before. I just want to say, hey, I totally support a work group. I'm looking to see if we can have universal healthcare in Washington, and so I'm like, so I take Emgality. Emgality is like its full price range is $700 a month just to prevent migraines, and so it's a super expensive drug. And so right now I'm on Medicaid, and so Medicaid's super great. And so right now within Washington State we were under a all the low people have, well, all the lower income are on Medicaid, and which is socialized. But then, of course, you have this gap where a lot of people just can, if they lose their employment, they'll lose their health care, which I totally disagree with. So that's why we're working on, or seeing that there's lots of healthcare gaps within our communities, and so I feel that it's a human right just to have access to healthcare. And so it's just because I know there's a lot of people out there, and so there's people who actually lose lives because they don't have access to healthcare. So I'm totally grateful for the work you guys are doing. I think that's it. Thanks.
Thank you. Okay, next up is Kevin Wren, followed by David McClanahan, followed by Joelle Kraft. Kevin, you can go and speak when you're ready.
Thank you. Hello, my name is Kevin Wren. About twice a month, I break the law because our health system exploits the disabled and leaves us with diabetes and other conditions rationing our medicine. I source insulin from Canada and around the country to send to those rationing here in Washington. I commit felonies over and over because our health system has failed the poor and middle class. Costs of medicine and care are beyond the reach of so many. It's a shame we don't prioritize their voice in this work group. This is only one disease which a third of our country and state are at risk of developing, a quarter of which are undiagnosed, and over 600,000 suffer from, according to the State Diabetes Epidemic Action Report. According to the CDC, 60% of US adults have at least one chronic condition, and over 45% have two. I shouldn't have to break the law to save lives. I shouldn't have to testify next to children afraid of rationing insulin. I shouldn't have to hear about stories of people moving away from the United States only to receive affordable care. Our lives are on the line, and you guys are responsible. We should look to reduce and eliminate social determinants of health because they're pervasive and crushing. Please, for the sake of the chronically ill and disabled, reduce any barriers to entry and implement the most progressive system because our lives depend on it. Thank you.
Thank you, Kevin. Next up, we have David McClanahan, followed by Joelle Kraft, followed by Jen Bartel.
I don't see David on here.
Okay. David, if you're here, can you raise your hand? Okay. We'll circle back. Next up then is Joelle Kraft, followed by Jen Bartel, followed by David Loud. Joelle, please go ahead and speak when you're ready. Okay.
Hi, everyone. My name is Joelle Kraft, and I am a lifelong Washingtonian. At 16, I was diagnosed with multiple sclerosis, and 26 years later, I was fast-tracked on disability, and I literally owe my life to my healthcare team. However, when I got divorced, I lost my insurance, and by losing my insurance meant I went on Medicare and Medicaid, which is okay, but one of the medications that my doctor has me on so that I don't get worse, so that I can keep doing what I do, is $14,000 a month. And although I'm on a program for poor people to be able to take the medication and they pay for that, they do not pay for the rest of it, which comes back to me at $900 a month. I make $850 off of SSDI. However, I have to pay $250 of that to Medicare to have health care. So I make $700 or $600 a month to live off of. That doesn't include my other medications that I have to pay for, that now I pay more because my ex's union had a contract. So the work that's being done here is extremely important, but we need healthcare for all, and that needs to include doing the work, again, like that we're all doing, but doing this so that we can be able to all survive and all be able to have the medications that we need, no matter what illnesses we have. Because there are people like me, like the gentleman who spoke or the person who spoke in front of me, that just want to survive. Thank you.
Thank you, Joelle. Next up is Jen Bartel, followed by David Loud, followed by Tanya Atkinson. Jen, when you're ready, you can go ahead and start.
Jen sent us a message that she no longer is going to provide comment.
Okay, then let's move on to David Loud, followed by Tanya Atkinson, followed by David Strider. David, when you're ready, you can go ahead and start.
All right. Hello, I'm David Loud with Puget Sound Advocates for Retirement Action and Healthcare as a Human Right Washington, a community labor campaign. Some members of the work group are rightly concerned that the main problem with a universal, publicly funded, publicly administered health plan is political feasibility. But let's think about the political feasibility of deciding that we will not be able to provide access to affordable health care to all Washingtonians. In the midst of the pandemic and an economic calamity we can only overcome with public health victories, how politically feasible will it be to leave hundreds of thousands of Washingtonians without coverage? And all those with coverage they dare not use due to high deductibles and copays. And all the essential workers who are undocumented. And all those who can become spreaders of COVID. How politically feasible is it to accept this prospect? Or to accept that we cannot do anything decisive about the racial inequities in health and healthcare? We understand that the legislature can't wave a wishful thinking wand. We understand that we need a Congress and White House which want healthcare for all. But our legislature can adopt a firm goal for universal healthcare and steps to make that happen, including real revenue reform. Our $4 billion plus budget shortfall is less than 7% of the $70 billion increase in wealth of just one of our state's billionaires since March. How feasible is that for our future? It will take elections and determined advocacy from constituents to move legislation. It will also help the legislature do the right thing if this work group is willing and able to do the right thing. Thank you.
Thank you, David. Next up is Tanya Atkinson, followed by Dave Strider, followed by David Harrow. Tanya, you can go ahead and start when you're ready.
Hi, I've been involved with this for several months, and I just think you guys are doing a wonderful job. I want to state that your recognition of inclusion and what this could mean to the state of Washington is wonderful. I did have a problem with the actuarial report on the last meeting. I saw that we weren't paying attention to the difference that having, please turn that down, that having access to having primary care would have in the reduction of ER visits. It is not appropriate to recognize that ER visits are going to go up. They're not going to go up if somebody has access to primary care. And I think that's important. I also saw in the homework last that I finished that we do not actually have a cost estimate for the Cascadia plan for the uninsured coverage. And so I have a problem with our assumption that Cascadia plan is not going to cost as much as A and B options. So having A option, I think that we need to be recognizing what the cost benefits are going to be for having that option for the total cost. And I think that recognizing that and taking that away from the total cost of what cost A or plan A will cost needs to be recognized. And I really appreciate what everybody's doing. And I think that's all I have to say. Thank you very much.
Thank you, Tanya. Next up, we have Dave Strider, followed by David Harrow, followed by Jennifer Perkins. Dave, when you're ready, you can go ahead and start.
I do not see Dave, David, or Jennifer, so I think we could go to Joseph unless any of them want to speak up.
Okay. So I'll just pause for a moment. Actually, well, let's go to Joseph and then I'll circle back and see if any of our others are here. So Joseph St. Aubin, we'll give you a second here. You can go ahead and start speaking when you're ready.
Yeah. Hello, members of the committee. My name is Joseph St. Aubin. And by the way, I apologize, my video camera is not working here. I support option A. When listening to this committee, when last it met, I came away with the impression that the committee could not figure out how to fund option A. An organization called Whole Washington funded a study to answer that very question. The study was performed by the same person that did the study for Bernie Sanders' national proposal for Medicare for All. The study concluded that the Washington State Constitution allowed for no more than a 1% state income tax, which would provide the necessary funding for a Washington State Medicare for All program, which I believe is the same as option A. If this is correct, someone from your committee should contact Whole Washington to learn more about the details of that study. To contact Whole Washington, just type in their URL, Whole Washington, spelled W-H-O-L-E, washington.org. Thank you very much.
Thank you, Joseph. Okay, yeah, I did see David McClanahan on the participant list, so I think we can go back to David McClanahan if he still wants to make a comment. David, if you'd still like to make a comment, you can go ahead and start speaking and I'll start the timer. David, should we take that as you're going to pass today? Okay. How about, do we have Dave Strider? Yeah, or is he joining us? Nope. What about David Harrow? Nope. Jennifer Perkins? Okay, then we are done with our public comment today. And we'll stop the share here. I think what I'd like to do is go back and see if Chris Bandoli's mic is working. Chris, how's it going? I don't see Chris. Okay, I'm just gonna check and see if Chris is still with us.
Can you hear me now?
Yes, wonderful.
Yeah,
hey, Chris.
I used my computer microphone's still not working, so I used my headphones to.
Well, thank you for problem solving.
Working now.
Good to hear your voice.
Great, thank you. So just very briefly, I'm Chris Vandely. I'm the Executive Director of the Association of Washington Healthcare Plans. So we're the trade association representing all the health plans doing business in Washington. I've been in that role going on a year. I started coming to work group meetings a couple months ago. Still trying to kind of catch up on all that I missed over the first many meetings where a lot was clearly discussed. So just looking forward to being part of the conversation and seeing how all this works out.
Wonderful. Welcome, Chris. It's good to have you here. Let's see. I think we're still expecting Sue Birch to join. I don't see if Sue's with us yet. The meeting might have run over a little bit. Okay. Jane, how about, I know we're sort of bearing the lead here, but do you want to go ahead and just say, walk us through the universal health care, achieving universal health care for children in Washington, and then Sue can sort of introduce that topic retroactively when she gets here? I think you're on. Let's see if we can unmute you here.
Okay, thanks.
There, okay. Okay, I'm going to share the timeline that you put together.
Liz, were you going to share the graphic? Perfect. So we've been having some discussions, I think, at the end of the last work group meeting related to just sort of the concept of incremental progress and sort of how one takes a long-term vision and actually puts it into place. And so thanks to Liz, we did some history, some historical research, which was really fun for me to go back in time to all of these great actions that were taken to get us to universal coverage of children in Washington state. And essentially you can see back in 1987 were some of our first actions, but what you can see in this progression is the legislature over a series of steps, knowing that there was always a goal in mind of universal access to maternity care and then to coverage for children, essentially building on prior steps to incrementally expand eligibility for services for kids, to incrementally expand which kids were covered in it. So for example, kids who were undocumented. And we just wanted to provide, I think, this as an example of how when a goal is set, an approach can be developed to get to that goal with legislative leadership and a very, very broad coalition of folks behind those goals. And I think what we can say is that as the legislature worked through each of these incremental steps, it tackled many of the issues that are before the work group today. So, for example, coverage of folks who are currently uninsured or not eligible for Medicaid by virtue of their immigration status, affordability and funding, cost sharing, scope of benefits, all of those issues, the way services would be delivered. For example, in 1993, the legislature said, yes, we'll expand coverage for kids to 200% of poverty if we take Medicaid managed care contracting statewide. So it was essentially saying, yes, I want to make a commitment to expanded coverage, but I also want to have, from the legislature's perspective, more predictability around what the cost of covering those kids would be. And the other thing that you'll see as you note this progression is that the legislature consistently took advantage of changes in federal law that provided opportunities to bring us federal funding to expand coverage for kids, much like the state has currently done with respect to ACA implementation in terms of setting up the health benefit exchange, aggressive marketing and outreach and enrollment, and of course, the Medicaid expansion, and then a number of opportunities that came up on the long-term services and support side. So we just wanted to try to provide a very concrete example of sort of a strategic approach to getting to universal coverage for kids. That's it, Jamie.
Okay, I'm just going to pause there. I see that Dr. Tritko raised his hand. I was just going to ask if he had any questions. So there you go, Dr. Tritko.
Thank you for that, Jane. This was, I believe, a program that Gary Locke initiated. And I'd point out that this program did not pay Medicaid rates. It had two separate sources of funding that paid much closer to commercial rates. But what the experience was with the state at the time, I believe, was that even with that enhanced funding, the overall cost went down as you took better care of these people. Thank you.
Thank you, Dr. Tritko. Any other questions or comments on Jane's? I see Kelly.
Thank you. So you're saying that this was a 27-year process then to get from 1987 to 2014?
Did we lose Jane?
Yeah, I think maybe so.
Okay, Kelly, I will mark the question and we'll get back to Jane when she returns.
Because I guess my comment would be we don't have 27 years. So I appreciate this was an incredible development in Washington State, and it was a lot of effort, and it was huge. But if we are considering a 27-year incremental timeline, we don't have that. And I'm happy to help develop a timeline, but it's not going to be 27 years. It's going to be 5 years, 2 years. What can we do next year?
So I see Jane back. Jane, did you hear Kelly's question? She wanted to clarify that she's reading this timeline right, that it was 27 years.
So Kelly, you're right. It was a long time, but I think the most significant part of it is looking at the time period from 2005 to 2009, because that was in 2005, that was the legislature passing legislation that set a statutory goal to achieve coverage for all kids. And then the big legislation was in 2006 when the legislature created a statutory entitlement to coverage for kids up to 250% of poverty, and then also said, you know, and up to 300% to the extent that funding is provided. And because of access to the Children's Health Insurance Program, that's pretty consistently been there. So I think in terms of big chunks, it would be the expansion of kids to 200% of poverty back in 1993, but then really the full commitment to universal coverage of kids, it's that period of 2005 to 2009.
And also, we have already learned a lot through this process that we can apply. So I'm really hoping it'll speed things up for us as we try to expand coverage to everyone.
Can I just make a really quick comment on what Jane just said, focusing from 2005 to 2008? You'll notice that actually, there's a red box here that shows some steps backwards. And that's when there was a really strong commitment made to say, we're not doing that again. We're going to put this in law. So.
Got it. Thank you so much.
So I see that Sue is with us. I want to take Aaron's question and Representative Macri's question, and then Sue would love to circle back to you and get your welcome. So let's start with Aaron.
Okay, so not really a question, just a comment about this, the timeline. Just another example is in the Health Services Act in 1993 that Jane has on her timeline. The commission that put together that proposal weighed the desire for speed against sort of the practicality of moving things along, and that law set an implementation schedule of 5 years to get from enactment to universal coverage. So just another model.
That's helpful context. Thank you. Representative Macri.
Thank you, and thanks so much for this, Jane. It's very helpful. And if this is one strong example of a path to a state level path to universal coverage, I think it's important to understand not only who is covered, but who's falling through the cracks. So I'm wondering if we can get information about the 3% of kids who have not been insured in Washington State. I think that goes to the equity goals we've been talking about. We're continually trying to strengthen this program, Apple Health for Kids, but also as we're thinking about a larger scale strategy, I think it's important to understand who's not getting coverage despite the intent to cover everyone.
Before I move on, do we have any response to that point or question from the project team or Jane?
I actually think that's a perfect segue to Sue and or Michelle, because they would be able to speak a little bit about who's not in that, who's not covered, and also
okay, let's turn it over to Sue then to do our welcome to our work group members and our guests. Sue, and I'll stop share so that they can see you. See. Sue, I think we're not able to hear you.
Can you guys unmute me?
Now we can hear you.
Okay, great. So I apologize for being delayed. We are truly in daily cabinet meetings and other kind of command meetings with all the moving parts. So again, please don't see my tardiness as anything other than we're juggling a number of things. So I think it's really important as we head into this home stretch as a work group, I think it's really important that we just make sure we kind of check where we are with expectations and deliverables. And I wanted to share some thoughts about what comes after our work together is finished. Before I do that, and I've learned to do this more often as COVID-19 and other impacts have created, I think, more humbling moments than ever. I think it's really, really important to thank all of you and our facilitators and the HCA team that have courageously pulled us through and kept the momentum going. I know you guys are all passionate and tirelessly working, and I think we all are truly into this notion of more affordability, more access, and more kind of equity and more kind of uniformity. I know that each of us holds components of this or all of it very passionately. So at the direction of the legislature, HCA intentionally designed this as a really robust stakeholder process that convened all the blend of perspectives. And you've heard it all, and we've heard it from our advocates, providers, insurers, small businesses, others. And really, we wanted this to be a very deliberative path forward. And we wanted to do our best around developing a report back to the legislature that reflected those diverse perspectives. In our charter, we really recognize this, and we acknowledge that the work group was not expected to come to a group agreement on all of its recommendations. And I think we would all agree at this moment in our country's history that we really validate diverse, respectful opinions and process are just a core piece that is so missing, and that we have emulated those principles. So we understand that the legislature, who's responsible for ultimately making decisions about how to implement universal health care in Washington while considering the diversity of perspectives around this table, would play out. And the meeting summaries that the project team has prepared really reflect this, and our project team is working hard to keep pulling together this final report that really does that. They've designed these last meetings with that goal in mind, to review and understand the different paths forward and solicit those viewpoints in light of the assessment criteria we developed together. So I know there are many, many more questions you may have about the models and the data and the details, and the project team is working hard to provide answers when that information is available, and in service of getting this report done and as complete as possible. But I think we have to keep in mind that the fine details are not the point here. The point is to outline the high-level path that highlights the estimated costs and expected savings, as well as direction about the next steps that can be useful for the legislature to take action if they so choose. By referencing the issues you've raised as important, we can make some high-level recommendations about those next steps. For example, key areas where more information is needed, potential work groups to study those areas or guide the implementation. But I do understand that the report is not the end of our journey and our work together. I ask that we all try to temper our expectations, especially since I think the next coming weeks and months are going to strain us a little bit more in other dimensions and domains. And in light of that, try not to think about the work that is essential now, but versus what is the future work for many of you as advocates and possibly as part of any future implementation efforts. So for example, I know many of you have been asking questions about the impact of COVID on the uninsured and healthcare coverage. We provided a briefing with our sister agencies a few months ago to all of you about what was being seen, and we have ongoing updates from OFM from September about the financial impacts. We know the impact is ongoing, and the project team and our state partners are doing as much as they can to give us that information when it's available. But they are also in the midst of trying to develop budgets, contend with substantial budget deficit and staff furloughs, deal with our federal partners asking all sorts of very interesting new questions about anarchists and things we could not have even begun to think about. All the while, we're meeting people's needs during the COVID crisis and carrying on. So while the report's going to mention the impact of COVID as part of the changing context and the advocacy work I fully expect many of you will be doing after the work group concludes, it'll put more current information at the center as to why the legislature acting on these recommendations is so important. So again, I really want to thank you guys for being steadfast, for being patient, for being productively provocative with our healthcare transformation journey. There are so many moving variables, and I'm just really proud that we were able to lift and do the work that we've done thus far, but there'll be lots more work as this journey continues. Back to you, Jamie. Unless
I'm going to remember the phrase productively provocative. That was a good one.
Last means stop saying healthy or positively conflictual. So
it's beautiful. And I love a good alliteration. I see a hand raised from Bevan. Bevan.
Hi, can everybody hear me?
Yes.
Great. So thank you so much, Sue. Much appreciated for all the work everyone's doing. I just wanted to just kind of emphasize that really it was a collaborative job of the authors of this bill, the advocates for this bill, that had the foresight to bring everybody to the table here. So I recognize that the Healthcare Authority has, been the administrator of this, but I want to make sure that Representative Macri, Senator Randall, and all of the advocates who were part of this also have a nod. The other piece of this is that as we move forward in our recommendations, I want to highlight that we have requested, multiple of us have requested for months now to hear from the Cascade Work Group and to collaborate, to hear the research that is coming out so that we can make recommendations that are realistic to the legislature so that we can make sure that we are giving the best that we possibly can to the Washingtonians of our state. So I respectfully request again, in public, to work collaboratively with the Cascade Work Group to really understand from them what they are looking at, what recommendations they will be putting forward, and how we can collaborate in that information, with that information, so that we can put together a 5-year plan, so that we can bring the residents of our state the desperately needed care that they need. So thank you again to everybody who's here, and I really look forward to the next few weeks.
Thanks, Bevan. I will respond. We are planning to have a pre-record about what's going on with Cascade Care for you guys in advance of the next meeting. So Pam is part of this work group, and Joan Altman, who's also been attending, has been ready to do that. We've just been waiting for the right time because there's been so much that we've been cramming at you guys. So that is one of the planned things between this meeting and the next one.
thank you, Liz, and I'll just augment that as soon as things are signed and publicly available, HCA will be able to discuss this a little more openly as well.
Great, thank you.
Okay.
I look forward to it.
Any other questions or comments before we move on to our discussion about the actuarial analysis? Okay. As I mentioned before, we're going to be staying all together in the main room. That was a good lesson learned from our last meeting, that when it comes to discussing the actuarial analyses, it's really helpful for all of you to hear each other's questions and the answers from both Shane and Jared. I also know I see if we have a few work group members who are on but are not able to turn on their video cameras. And so for those of you work group members who've joined by phone, you can, if you want to raise your hand and participate, you can press *9 on your phone, and that should signal to me that your hand's up and I can call on you. Worst case, if you are wanting to say something and I don't call on you, please do just jump in. We want to make sure we hear from, I think it's Patrick, Connor, Chris, Shafton, Powell, and Senator Randall are all with us, but not on camera. All right. So hopefully all of you had a chance to review the follow-up presentation from Shane and Jared. Shane gave the presentation and the pre-recording. We have a number of questions that they had left for you also in the slide deck from the last meeting. So I want to cover those, but before we dive into that, first of all, thank you to everyone who submitted really good, thoughtful questions. Hopefully you saw the responses posted both to the HCA website and what I sent out to you. Before we dive into our questions for you, wanted to see if there were any other clarifying questions that have not yet been asked and answered. I'll pause and see if there's any hands up here. It looks like we were very efficient then in our back and forth communications. That's, oh, I see that. I spoke too soon. Dr. Tricko. Let's see, let's get you unmuted there.
So a question that I posed after this, as you know, seems like we've devoted the vast majority of our times to Model A and B. I understand that. And we've devoted far less to Model C, but Model C is also very complicated, very timely. And I just think at some point that we ought to devote as much time as we need to Model C, and in particular to pay attention to all of those who are either uninsured for whatever reason, and there are a variety of reasons, even when they have access to coverage. I think those that are in the exchange currently do not have access to affordable health care. Exchange plans are very expensive. The deductibles are outrageous, and they're limited networks, so the out-of-pocket maximums are meaningless. I would also say that we need to address undocumented immigrants and people who have barriers to care even though they have coverage. And then finally, our governor last night at the WSMA meeting brought up his fear about 800,000 people that are going to be left without coverage if the ACA is struck. So to me, reality is in Model C, and I think we need at some point to devote a lot more time to it. Thank you.
Thank you, Dr. Tricko. Aaron, I see your hand up here.
Yeah, I don't want to reiterate I sent it a bunch of questions that I think were not answered in the formal, that PDF that you sent. At least I didn't see them. I may be wrong, but I I think there were some things that I raised that were not responded to at that point. I don't have the questions in front of me myself.
Okay, we'll look into that, Aaron. Our apologies if we missed some of your questions.
Were these
Did you have
the
any that you
questions
wanted?
from, oh, sorry, were these the questions from the last couple of days, Aaron?
Yes.
Yeah, so we've answered those, but we haven't sent them to you yet. We just finalized them this morning. Okay. We'll be adding them to the PDF later.
Okay, thanks.
Okay, other clarifying questions from folks before we start firing some at you? Okay, well, Dr. Tricko kind of segued neatly to one of our first questions, which you should have seen in it was the slide deck that I sent you after our meeting in September. It was the one that Shane and Jared presented, and they included their questions for you summarized at the end. And that question is just based on what you've seen in these analyses and also the responses to the questions that you submitted, do you want to adjust any of the design elements in the different models that we're analyzing? So I heard Dr. Tritko not necessarily saying let's adjust, but let's pay some attention to option C, which has not been popular with some work group members, but maybe from Dr. Tritko's perspective, a practical choice given the times. What are some other perspectives, if any, on how these models were designed with respect to the choices made around benefits, who's covered, how the assumptions we're making about provider reimbursements and administrative cost savings? I see Aaron's hand up again. Let's unmute you here. Go ahead, Aaron.
Sorry, yeah, so this does go back to some of the questions I raised. So one of the things I raised, well, let me actually just reflect on Dr. Tritko's comments. If I understand the point of this whole exercise, it was to develop, well, I think the phrase is pathway to universal coverage. So it suggests that we lay out the goal and a set of steps that are going to get there. And I think a number of us have talked when we've referred to model C, is we recognize that sort of status quo process of incremental change may well be part of the pathway, or does reflect the pathway. But I think those of us who, quote, object to Model C, object to it as the goal, okay? So I think we have to keep our eyes on the point, which is universal coverage and a path to get there. So just to say that. In terms of the elements that were in the actuarial analysis, one thing I pointed out, what I suggested is that what I would like to see some estimation that would include Medicare as a population. The actuarial analysis, it was sort of the one group that was, well, that and other federal groups like veterans were specifically excluded. But what I pointed out in my questions is that depending on what happens this fall with the election, it's possible we could see, and of course with the Supreme Court's consideration of the Affordable Care Act, it's possible that we could, the state could have the opportunity to seek federal partnership in including Medicare. So I think it's incumbent on us to see what that would entail. The people and the money that would entail. The other point I made, and I followed up with some additional information, is I think the estimates of administrative cost savings from Model A, probably from Model B too, but definitely Model A, are pretty pretty low, too low. And I suggested, I sent some reference material that I think would suggest a significantly higher savings for administrative expenses.
Thank you, Aaron. I just want to pause a moment because there's a lot in there and I want to make sure we capture all of that. So first of all, with respect to your comment about option C, I hear you saying that many of you might see option C as a step on the pathway to option A or B. I do want to remind folks, and maybe perspectives have changed, and it would be really helpful if you could clarify that for us today, that when we discussed the models, gosh, was it in August? It's hard to remember now. We did hear from a number of you concern about doing option C I'm worrying that if we even use that as an interim step, that would be the last stop, that we wouldn't get past that to option A or B. So I just want to remind folks of what we heard in August, and please do let us know if your perspective has changed on this, especially as we've been talking about implementation steps. To your point, Erin, about administrative costs, you were not the only one who raised questions about those assumptions. I think there were a few people who raised those questions, and I believe one of our public commenters had something to say about that today as well. And then finally, I wanted to pause for a moment and see if Shane or Jared wanted to say anything about Erin's comments about Medicare and including Medicare population. Shane or Jared, anything to say there?
I can jump in. So I'll try and address a couple of things here. First, we did build the model so that we can include and exclude populations relatively easily. We tried to keep it dynamic. Medicare is actually one that we have all of the detail mapped out for, and we can easily include it. So we're fully intending to show you a version with Medicare and a version without, both for Model A and for Model B. Similarly, one of the types of feedback we get is that, there isn't universal consensus on what this looks like. So that does necessitate looking at a few different options. One of the other ones that we've been requested to look at is modeling with no cost sharing, and then modeling with more status quo cost sharing. And that's also something that's relatively easy to adjust within the model. So in terms of providing a couple of different slices of views to really inform the best decision possible out of the work group, we are going to provide a couple different scenarios. And when we get to kind of open discussion here further, if there are other really key areas that would be important to see how it might look with a slightly different scenario, let us know, and that's certainly something that we can look into. So we're happy to provide that. The second point regarding the administrative cost savings, I just want to clarify, I believe this is most specific to provider administration and not our assumptions regarding the really big ticket administrative cost for the delivery system, because those are the relative magnitudes are pretty significant. And I really just want to provide context on kind of how we're thinking about that assumption, and then maybe we can just have a conversation about whether maybe some of our thought processes could be improved on that. That was a really poor way to say that, but you know what I mean. So the model is really based off of what we expect the first year costs to be. And in thinking about how the first year of the universal healthcare model will look from a provider perspective, there's going to be a lot of efficiencies that they're going to see under universal healthcare that are going to take some time to be built into the model. And just to give a handful of examples so that you can understand that we really have tried to think through this with some great depth. But when providers bill for services, they're billing for services after they happened. And that billing process can take, in the case of a hospital, it can be 6 months where they're still going back and billing the payer based off of the date of service. So there's this period where providers are still interacting with the historical payers, even though you're into your future state system. That's not the biggest driver per se. It's just one example of that first year is going to look a little bit different. The offices themselves are going to have resources that are dedicated to processes that they may not phase out those resources on day one. They may need that clinical and administrative support to deal with administrative audits, closeout of value-based purchasing contracts, final settlement. That's just another example of that first year that administrative burden is still present, but maybe in a lower form. I have one other really great example, and I can't remember it off the top of my head, but the key point here is that we've tried to think through how things look operationally, and while recognizing that there's tremendous opportunity to be more efficient, you just don't see that day one per se. And so we really need to temper our expectations, because if you were to cut provider reimbursement while they still have administrative burden baked in, you do risk destabilizing access and quality of care for the same people that you're trying to serve. So that's kind of the high level concept of behind why we've tempered those first year assumptions. But again, we really need your feedback. You have that boots on the ground perspective. So I'd love to discuss that a little bit if we could.
I see a lot of hands up, and I do want to devote some of our time to discussing the administrative costs, but I also want to make sure I get to our folks who've been patiently waiting to make comments or ask questions. So what I'm going to do is I'm going to call on Dr. Tritko, Pam, Kelly, Bevan, and then Aaron's hand is up again. And then I'd like to circle, oh, and I see Beth waving her hand too. I'll make a note, Beth. And then we can circle back to the administrative discussion. So Dr. Tritko?
Thank you. Model C again. I think that the model's goal is to get to universal access. I disagree with people that say we can't. The covered population should not be just undocumented immigrants. It should be everybody that's uninsured. And there's at least 4 different reasons for that, as well as people who do not have access to affordable coverage, which I would say is everybody in the exchange. If I was sitting here with a nice Regions Blue card as a retired state employee, I wouldn't be concerned, but I'm going into the exchange next year and it scares the crap out of me. And I don't think it's affordable coverage. So I think Model C needs to include all of those populations. And to disagree with Aaron, our path to getting a waiver depends upon our ability to form a very large accountable care organization that has global budgets, that has risk sharing, just like Maryland is being required to do because they have a Medicare waiver. I was on the board of a health plan called Unified Physicians. That was a startup. They don't go well. We have to have a track record in this state with an ACO that works. And if we take the state employees and we take this other population, we're going to have between 1.5 to 2 million people. We can prove that it works over a couple years. Then we can go and ask for federal waivers. But to think we're going to jump right into this, I think it's going to be extraordinarily difficult to do. I've been there, and it didn't end well, as some of you may know. Thank you.
Thank you, Dr. Tritko. Let's see, I think Pam was next.
Thank you. I just wanted to also associate myself with those who would like to see option C be a little more fleshed out. I think that I was glad to hear you explain why there was sort of an aversion to doing that. I'm afraid that you create a different path that would distract from the others. But I feel that if it's not, if we don't put more time into it, then what is likely the most feasible option as a pathway to universal access won't have enough content to it, and you'll miss an opportunity to kind of weigh in on the things that are most important. The Affordable Care Act has been, systematically eroded over the past 4 years, taking away cost sharing reductions and reinsurance, which has had a huge impact on premiums and cost sharing for people who are in the exchange, which is why it is unaffordable, not for everybody, but it is affordable for many, particularly people who are over 55 years of age and are not eligible for subsidies. Those folks get hit. And although we're trying to patch that up at the state level, it's hard to do, piece by piece. It really needs a comprehensive approach. There are also problems with the Affordable Act, like the family glitch, things that need to be addressed that hurt people individually. That, I'm just, I think a lot of us would really like to fix and really like to approach. The other thing is the very large number of uninsured. And I think I agree that there are lots of reasons that people are uninsured, and there needs to be more focus on that. And the best way to get at that is to create affordable coverage, affordable, accessible coverage.
Thank you, Pam. Okay, Kelly was up next. Kelly? Oh, Kelly, you're still muted. There you go.
Okay, so I have not heard anyone asking to include cost sharing. So I'm just wondering who that is. I mean, every meeting I've been in, it's been resoundingly no cost sharing. So I'm just curious about that. And then And I think I'm misunderstanding some of the written comments, and I'm not remembering, because there were so many great questions in the written responses for you guys. But are we just looking at first year costs and not out to 5 years even? So is the final report only about the first year? I thought I heard.
Shane or Jared, do you want to answer that one?
That's what we've currently modeled. Yes, just the first year. Plus, I think we're up to 12 different iterations of different scenarios. So I think in terms of capacity, we can either look at a whole bunch of different scenarios, or we can look across time, but probably not both. Because then what would happen is you're looking at 60 different models essentially, because you'd have 5 years for 12 different scenarios.
Even like really broadly, because to me that's like saying, you're saying to somebody, it's like a business proposition where you're going and saying we're starting this new business and it's going to cost gazillion dollars the first year, and then we don't get to talk about all the savings that are going to happen over time after that. It just seems really, almost, I would have to say, unacceptable. So, and I understand the problem of all the workload that you guys have. So we need to contend with that. We need to come up with something.
Yeah, so we are going to speak to savings potential and talk about what is, what some of the research around that is. But we're also using data from 2018 for the projection. So when you're talking about forecasting 5 years past 2022, you're also talking about a level of uncertainty that maybe isn't representative of reality at that point. So
yeah, and I mean, and with COVID and with the AC, I mean, there's so much that we don't know. But I mean, I think we're all adults and we know that, but we have to do the best with what we have. I mean, I don't think it's an option to just say, oh, we won't talk about after the first year, because it renders it almost useless what we're doing. So that, and then the no cost sharing, could we get an answer on that? I'm just wondering who's driving that.
We
so
received, sorry, go ahead.
Go ahead. Sorry, Shane, you go ahead, please.
It was, I don't remember who submitted the question, but it is in the FAQ. Essentially, the comment was that there wasn't unanimous consent on excluding cost sharing, and that we should potentially address that in the report. I think just thinking about the
cost. We come to a group decision on that. I mean, because we might be able to say, no, we don't want you to do that, because the majority doesn't want that done.
So I'm gonna speak up here, and this is what Sue was speaking to at the beginning of the meeting too. This is not a consensus-built group. There are people in the group who've also spoken with me privately about their concerns about the cost sharing.
Okay.
So I think that what we need to do in our report is represent the perspectives as accurately as we can. So there were some people that said they weren't wholesale against cost sharing in our work group discussions, and then there's also been some people who've spoken with me privately about that, and we'll have to characterize that and not call it a group agreement.
I'm just worried about the scope of work.
Okay. Let's see. I think Bevan was next, followed by Beth. Aaron, looks like you put your hand down. Bevan?
First of all, thank you, Shane. You guys are doing a lot of work, so much appreciated. I guess my question, so you guys did a really good job, I felt like, of giving a visual in your first slide deck of where you were pulling the costs from, which included, public, private, as best as you could. I understand that there was some computed things in there. For me, it would be really helpful to also have a visual of where those savings are allocated. Whether that's to the state through a Medicaid program, whether that's to private individuals, whether, where those approximate savings, that I recognize that's not something we can go down to the dollar on, but to kind of visualize that. And I think, I hope that other people might be with me on this, but in terms of the conversation around quote unquote feasibility, there's two components to that for me. One is the political feasibility, right? And in order to be able to make this politically viable from my perspective, I need to be able to talk to the small business community and say, hey, look, under Model A or Model B, whatever, these are a projected savings at year 1 through whatever we go through year 3, year 5, right? Et cetera, et cetera. So, and then in terms of the feasibility of the program itself, and the nuts and bolts, I think it would be really helpful to understand, if where the savings are allocated to the state, as an example, where we would be able to give or potentially pull revenue to help support those particular components. So in terms of visualizing the feasibility, both politically and then just in terms of the administration of it and the funding of it to the legislature, I think both of those are really, really necessary to have. So I would be really grateful if we could do that.
That's a great point. So our next step with the modeling, other than kind of shoring up some of the assumptions based off the feedback we're getting, is that we are going to look at kind of the revenue side rather than the cost side. So, like recognizing that you have this subset of Medicaid eligible, this is just one example, of Medicaid individuals that currently get some level of federal contribution and then a whole mix of state funds that support their provision of care. But under a universal healthcare model, presumably expenditure for that population will be higher because the level of reimbursement will be kind of normalized across the whole system. There will be some access increases for that population, which drive up good utilization and drive down bad utilization. So what we don't yet have, or actually let me back up one step. So we are planning to look at the revenue side. So if those programs or all of these different populations maintain their same type of funding stream, we'll be able to show what the differences are by population. What we don't have is what the actual official way of funding things will be in the future. So depending on how the tax is structured, that's going to create the winners and losers, so to speak, in terms of revenue contribution. I think what we're providing is going to give you a really concrete, good view of what dollars were flowing in and what dollars are associated with which population, so that you can start to think about that issue. I just want to be really clear that we don't quite have that last piece that we can overlay for the comparison.
Great. So I guess my question would be, can we have some visual and some information on that before the final report is written? Because I think it would be very informative for this group to, put in terms of our recommendations.
Yes.
Thank you.
Beth, you're up next, and then Patrick's got his hand up.
Yeah, thanks. And I appreciate actually starting off this segment with the timeline that you presented, Jane. I think it's a really helpful reminder of how do we get to an end goal, but sometimes there are those incremental steps. And I agree with Kelly that we don't have 27 years or whatever it was. And, the reminder that there was a time frame in there that really had a lot of that change. So I find myself actually agreeing greatly with Dr. Tritko and Aaron as far as, how do we develop a program? I think, again, we're not talking commercial insurance, the Microsofts, the Amazons, the folks who have a Regions card or, other. We're really talking government programs, and we've had great success in government programs along the model that Jane was outlining around, populations and total cost of care. And, how we have those and how they've progressed over time. And so I do support more us looking at option C as an incremental approach to get to the other options, because I think that's going to be the more feasible short-term approach to get us populations of people into a program that more closely resembles some of what has worked in getting people insured around Medicaid and around Medicare.
Thank you, Beth. So I'm definitely hearing some movement from some of our work group members toward looking at option C as a step toward moving to our end goals. Let's see, Patrick, followed by Dr. Kovar. Patrick? Oh, hello, Patrick.
Hi there. Sorry, we had multiple Zooms going on at the same time, so I had to be off the camera in order to make sure nobody got dropped. Jamie, but trying to go back to what I think was part of your initial question, it feels to me at least a little bit like we were sort of presented with more or less 3 choices at the outset that ultimately were boiled down to A, B, and C, but we had an A or a 1.5 and a 2.5. And some of the groups I think delved into those a little bit more deeper than others. But it seems like a lot of the path that we've been on so far has been driven, I think, by some of the voices talking the loudest. And because they hear their own voice so often, I think there are certain assumptions that everybody else thinks the way that they do. And I'm not sure that we really had an opportunity to discuss things like co-insurance, cost sharing, what the value is in some types of cost sharing versus others. And it was mentioned about reimbursement. We've had very little conversation, at least with the groups that I've been in, not enough time to really get into some of the trade-offs and talking about what reimbursement rates might or should look like and how they might differ between the different options A, B, and C. So I know we've had a kind of compressed timeline made worse by bomb threats and bomb scares and COVID and moving to a virtual kind of work environment, and probably not enough opportunity to have some of the natural offline conversations that would happen if we were meeting in person. But I think in general, the draft report, I think, kind of summarizes more of, again, the people who have talked the most, have made the points the most, and some other voices maybe haven't been heard at all, or at least certainly not as loudly.
Patrick, thanks for making, I'm off mute. Yeah, Patrick, thanks for raising that point. It actually reminds me of something I'd wanted to say to all you in the context of drafting the report. And we just touched on this a moment ago with the question that Kelly raised. Again, this is not a consensus expectation group. It was not structured to be that way, and that's how we also outlined our charter. We, as Sue mentioned in her welcome remarks, this is really a robust stakeholder process. And what our objective here is to provide the legislature with as accurately characterized perspectives from a lot of the key stakeholders in this whole process. So I recognize that, yes, it's been a very compressed timeline. And I also recognize that some of our workgroup members may not be in a position to be as candid in some of these conversations as others. So one of the things that I am doing over the next couple of weeks as the HMA team is going to be working vigilantly to draft the report is reaching out to some of you individually, particularly those who have maybe not been as vocal in our meetings, and where I think I might not clearly have my head around what your perspective is. So you'll be hearing from me. Also, if you don't hear from me and you do want to talk to me, I'm always here. So please do reach out to me if I don't reach out to you. But my intent is to be proactive in contacting some of you and having some one-on-one conversations. The point being that even if your perspective isn't deliberated in the workgroup meeting, it does need to be captured in the report, and that's how we are going to be doing a service to our legislators. So thanks for raising that, Patrick. Let's see, Dr. Kovar has his hand up. Dr. Kovar.
Thanks. You know, I'm listening to the resurrection of the idea of option C, and it's a little different than I remember it, but I really have to say that it feels to me like we're raising this because the 800-pound gorilla is still in all of our rooms. And if that 800-pound gorilla stays there, that may be the only option we can be looking at. And I'd like to be more optimistic, but that's the political reality of this. I would say, and I do want to applaud Shane and Jared to hopefully we'll get down to some of the numbers in this for the assumptions, but did a great job with the modeled populations overview. And I do realize that my eye fell on the smallest line item, but it will be potentially a politically large line item that the legislature has to struggle with, and that's the undocumented immigrant, who might be best served by option C. But I did want to, the number struck me of 120,000 that is in the overview sheet. Now that comes out to something like, I don't know, 1/500th of the entire expenditure. So we should keep that in mind, that it's very small, but it's, you know, people will want to argue about that. When I looked it up, that 120,000 was actually nearly twice that in the number of undocumented immigrants in our state. I think it's an important point. We have something like 16,000 DACA kids in this state. Those are important, that should be recognized. And the undocumented are about 23% of the immigrant population in our state. So I just would want to at least look at that number again, see if that's 124,000 costing $98 million, or is that 98 million spread out over twice that number? But again, recognizing that the public relations part of this will be important. We're really talking about even that it's somewhere between 1 in 250 and 150, and 1 in 500 in the total expenditure dollars. Thanks.
Shane, did you want to reflect on that, or should I move on to Aaron?
Just quickly, we're trying to align our assumptions with the assumptions being made for the subsidy program. I know that we're going to have to update that number to reflect their most recent analysis prior to their November report. Whatever number we land on, we'll have the same number between the two programs, but we'll make sure that it's tight.
In the back of the napkin calculation, if there's 11 million people undocumented in this country as an estimate, we're 2% of the population here. There's no real reason to think that we're different than 2% of the undocumented population. Thanks.
Aaron, you're up next.
Thanks. I just want to make the point about I guess this is, the sort of thinking about Model C and the discussions about specific groups like people who are undocumented, is to remind us that lasting healthcare reform requires a system that controls spending. And the patchwork process that we've been on forever, and which is reflected in Model C, provides no capacity to control spending. I think that's been demonstrated well throughout my career. So that's 40 plus years. So while I appreciate that there are elements, and this is sort of kicked off with Jane's timeline, which I think is a good example of how you can incrementally expand coverage. But when the next pandemic hits and the next recession caused by it hits, we are going to retrench on coverage because we won't be able to afford it. So a big part of the goal for me, in fact, is to me the overriding objective of an effort like this is to create a system that can control how much money the healthcare system consumes. And Model C just won't do that.
Thank you, Aaron. Dr. Tritko's next, but I want to just pause for a moment because I'm really appreciating, Liz and I were just doing our usual chatting back and forth because we're really appreciating the level of discussion here. And in fact, in many ways, you're touching on some of the issues we were going to discuss in our breakout groups later around goals and objectives for this, and also some of the bigger questions about how we characterize areas where we're not all in agreement. And we still have to, I promised you we'd go back to the discussion of administrative costs. I know Shane and Jared also want to circle back on some of the questions they had regarding the benefits that we include in this modeling. So here's what we're going to propose. I think we'll take Dr. Tritko's comment, and then I think we'll still take the stretch break, 5 minutes. And then I'd like to come back to this discussion and we can continue covering this until we feel like, first of all, until I get the thumbs up from Shane and Jared that they've gotten the questions answered that they need to complete their modeling. With whatever time that we have left, we can start to dive into the goals discussion, but that's also something that Liz and I feel like we can carry on via written feedback from all of you between this and our next meeting. So we're not super concerned about not getting to do the full discussion today on that. So that's the plan. Does anyone have any concerns about that shift? Okay, good. Thanks everyone for your continued flexibility as we adjust to the needs of this group. Dr. Tritko.
Well, I just have to point out, in fairness, I have never said anything about a patchwork system. What I've proposed is more in line with what Maryland has done, is to put millions of people into an accountable care organization. That's what the state needs to do. We have this very large population of people that are uninsured and underinsured, as well as state employees. You form a very large ACO. You change the payment structure to make it risk-bearing. You get global budgets. You make it work for a few years. Then you take this very large system and you apply for waivers. So I am not talking about what Dr. Katz says I'm talking about. I just want to make that very clear. I'm talking about more in line with what Maryland is doing. Thank you.
And I just want to make sure we also capture Aaron's point, because I've heard him say it before, which is ultimately our goal still needs to be, and Aaron, please correct me if I get this wrong, but our goal needs to be the cost control, and that ultimately will require solving the fragmented system. So in fact, I think Dr. Tritko's point about option C doesn't preclude what Aaron's talking about as a future end state goal. Is that accurate? I'm seeing Lynette nod, so thank you for that, Lynette.
Yeah, and can I just say, Dr. Tritko, I wasn't aiming at you. So, you know, Rich also was talking about a specific population. I wasn't aiming at anybody. I just want to make sure that we keep our eyes on the prize here. That this is not, if all our goal was how do we fill in the gaps in coverage, we wouldn't need this really great group of really smart, experienced people. We know how to do that. Jane can do that. You know, she's got her algorithm on her computer. She could do that herself.
But don't you think it's not going to be 60 to 70 tiny exchange plans covering 200,000 people? It's going to be one very large ACO covering a couple million people. That's where we can get some market power. That's where we can get global budgets. That's where we can go to a risk-sharing payment system and get the data to get the waivers. So I'm talking about something totally different that I think is something we could do.
All right, folks, I appreciate the provocative productivity. We're going to take a 5-minute stretch break here, and then we'll come back to this discussion. So I have 2:32. I ask everyone to be back here at 2:37, please. Thank you. Hey everyone, we'll just give folks another minute to get back into their chairs and get their cameras back on. Okay. Vicki, you're next. I'm just going to wait till Shane's on before we take your comment in case, presume him, there he is. Okay. All right. So up next we have Vicki's hands up, and then Pam, and then Kelly. Vicki?
Oops, did I do it right? You can hear me?
Yep, you're good. Yep.
I feel like I'm on a game show. So I've been really quiet today. I feel like we went backwards. And I know I haven't been with this group very long, but I've been following along. And I just want to speak to the cost sharing issue, because I want people to understand that that's not a savings problem, that's an equity issue. When we institute cost savings or cost sharing, co-pays, especially deductibles, we're keeping lower income people from receiving services. So to me, that is a huge equity issue. If we want to save money, then limit benefits, or in some other way, but don't keep people, people who have enough money will be able to go and see a doctor, and people who don't won't. And that is clearly an equity issue. So I want us to really understand that. And that's all I have.
If there are any folks present who want to speak to their particular thoughts on cost sharing, please do speak up. I understand that again, there may be situations where some people are not able to do it in a larger group. Let's see, I see Pam, and then Kelly's after that.
Thank you, Jamie. For better or for worse, I was going to get in on the Maryland discussion. And I just wanted to point out a couple things. Maryland has a very active exchange, and they do some things that are innovative, but they're different than what Dr. Tricco was talking about. They have their own state reinsurance program, which has kept their premiums much more affordable. And they also do some things in terms of bringing low income people into coverage. I think they almost have an auto enrollment, but they would bring them into low cost, no cost sharing coverage. They also have an individual mandate in their state, which is likely out of reach for us because we don't have a state income tax. They have a cost control mechanism for their hospital costs that is unique in the United States of America. Makes a huge difference in terms of healthcare costs in that state. And I have to believe the ACO that the doctor was talking about has to do with Medicaid and leveraging purchasing power for Medicaid. I don't know that for a fact, but I think that what you have there, start to have there is kind of a constellation of innovative programs that make a difference for the whole, all the consumers in the state. And there are other states that are equally impressive that we could be looking at.
Kelly's up, and then Sybil, and then Shaston has her hand up. Kelly?
Hi there. I'm wondering if what's happening is that we're starting to veer into a timeline for how to implement inadvertently. And we're having this discussion that we're thinking about it in terms of end goals, but it's really about how do we get there, and option C is stop along the way. How much of option C is a stop along the way, that sort of thing. So I just wanted to raise that as a possibility. And then I have to say, Jamie, when you said I will have these private conversations with people, I was like, what is that? help me understand how that's like a democratic open process. I mean, that was concerning to me.
Would you like me to speak to that a little bit?
That'd be great.
Okay. So I understand your concerns about some feedback being surfaced in private conversations. The challenge with a work group like this is there's representation on this group. Some people are on this group and they have roles within their organizations or other reasons in which it might not be possible to be as candid in this discussion. Now, the challenge, of course, with raising issues privately to me, for example, is that there's not that opportunity to deliberate on them. Yes. What we're aiming for here, as I said, is a report that captures the range of perspectives of people around the table. And the idea of doing this in a work group as opposed to just doing a survey of everyone who's here or a survey of the public and sampling different groups is that after all of the deliberation and hearing each other's perspectives and also seeing the information that Shane and Jared are producing, for example, people are processing that and it may be shifting perspectives. And in fact, to Vicky's point about us going backward, one of the things that's interesting to me today is that when we talked about the 3 models in August, I heard a lot of feedback from people at that meeting that option C was totally unacceptable. And there was a real fear from people that if we did option C, we would just stop and not move forward with option A or B. That if option C was something we would look at, it would be if it was very clear that it was an interim step to option A or B. And so what's this, I'm surfacing this as an example of after some deliberation and consideration. I haven't heard anyone today say that they think option C should be our end stop, but I am seeing a lot more interest in considering that. And I think it's probably because of the information that we've been looking at over the last couple of months and all the deliberation that this group has been doing. So Kelly, to your point, it's an imperfect process, but it's also, I think, the reality of the structure of the work group and what's before us in terms of what we can present to the legislature. And one of the things that I'll be asking all of you to look at when you get a draft of the report is, have my perspectives been accurately captured in here? And are there things in here that I would like to respond to? Because I don't, and you know, Vicky's point right now about responding to information surfacing that there are some folks in the work group who have spoken up at other meetings, but who may not have been as adamant about maintaining cost sharing, and her saying, "Oh, here's the perspective of why cost sharing could be really problematic." So that was a lot of talking I just did.
Could I get an agreement from you that there would not be a conversation that went straight to the report without it being represented in the group for us to have a dialogue about before it goes into the report?
I think that's a fair request. Yes.
Thank you.
Yeah. I think that's a fair request.
Yeah. Thank you.
Okay. I see Sybil and then Shaston. Let me unmute you, Sybil. Sorry.
Oh, I unmuted myself. Thank you.
Okay, good.
Or someone else did. I just wanted to echo what Vicky said about the equity issue with cost sharing. Yeah, I don't think I have too much more to say. Just want to echo that and have it be on the record that we agree with that. And we know that people use their coverage less when they have higher costs. So if we're trying to have people actually use whatever we produce, then there has to be low barriers to using it.
Thank you for jumping in there. Shaston? See if I need to unmute you. Let me. I'll try to unmute her. Here we go. Shaston, are you able to speak? I'll try again. New York, Liz, can you help us out here?
Yep, 1 minute.
Okay.
Can you try one more time? Yep.
Okay, I'll try again. Oh, I think I got it. Hold on. It worked there. Oh, no, it went away. Jasmine, you want to try to unmute one more time?
Yep.
There we go. Yay.
Oh, all right. Thank you for working on that. Sorry, I'm on this old computer today, terminal with no video and no mic. So yeah, I just want to also emphasize Vicky's point there. I think we really need to keep a focus on affordability, because that to me is the key of what you really could be universal health care and access to health care for Washington State. I do not like option C, and I think Washington State is a step ahead of that. I feel we're going backwards too. We've been there, we've tried that, we've had basic health. I think it'd just be staying where we are and try to put something forward that's already been tried. I also know that I've asked before, and I still want to see if there's possible to give data if cost sharing ends up staying on the table. What is considered affordable for the average population? I don't know if there's data available for that. What is reasonable for a deductible and monthly premiums and adding co-pays and co-insurance on top of that? And it also probably links into with Dr. Katz there about keeping the cost containment as a factor of that. And because I'm very concerned about the equity in healthcare, and I think the pandemic, if anything, has really highlighted that. And it's something that's really been felt and experienced in tribal countries. So thank you, Vicki, for speaking up.
Thank you, Shastin. So I want to make sure we're capturing these perspectives, and I think we have both at this meeting and at previous ones, that there are a number of people around the table who have concerns about cost sharing because of its impacts, first of all, on equity and access for people for whom premiums or co-pays or co-insurance would represent something unaffordable. And I hear Shastin saying that our goal, one of our key goals, and this is one of the things we were going to talk about today, is around maintaining affordability. Does any of our HMA team have a comment? I know we talked about this actually, I think in February, or any information about where data might exist around what even constitutes affordability with respect to cost sharing? I don't think we've turned anything up at this point, Liz.
So I'll say something and then Nora chime in, please. You know, the ACA has standards for what they say is affordable, but we all know that those are probably not affordable. And so I'm going to have Nora speak up more here, and what other states have, well, what one other state at least has done around affordability.
Yeah, I mean, I'm hesitant to get too much into the idea of what's affordable, because I think, as you know, what's affordable really is dependent on your financial situation, your life situation, and even two people with the same family size and income, if one of them has a chronic condition, may have more needs for care, and so, you know, what they're going to have for available to spend on healthcare may be different. I think the research is more about the impact that, and we have talked about this a bit, that the impact of cost sharing expectations on utilization, and you know, going as far back as the RAND study in the 1970s, indicating that people are cost sensitive, particularly at lower income levels. So I don't really have a good answer on what's affordable, because that's a pretty complex and maybe also political conversation.
I'm going to take Aaron, and then I'm hoping we can dive into the question about administrative cost savings. Aaron?
Great, thanks. Just two things about cost sharing and affordability. One is the only estimates of affordability that I recall were estimates, one by, I think, Families USA and another by the Kaiser Family Foundation, but they really didn't relate to cost sharing per se. They related to what families or individuals paid for healthcare, which would include, everything. So it'd be premiums as well. So I'm not aware of affordability analysis related to point of service cost sharing. So I'm agreeing with Nora that that's a difficult arena. And just to riff on Nora's point that there are a couple of issues. One that a number of people brought up around cost sharing being an issue of equity, but remember that cost sharing was instituted, cost sharing is instituted for two reasons. One is to help fund services. So we want, so just one source of money, but the other is to influence use rates. And as I've said a number of times in these meetings that, personally, I'm not against all cost sharing. I'm against cost sharing that inhibits people from getting access to services and punishes them for seeking services that they need. And I think the research is underwhelming to demonstrate that cost sharing is an effective tool to reduce wasteful use of services.
Patrick, I see your hand up.
Yeah, thanks. And I don't want to belabor the point too much, but since cost sharing keeps coming up, I'm a little unclear first whether we have a position, and again, I know we're not trying to reach consensus on things, but in this new frontier, are we hearing that there would be premiums? And if so, is premiums considered part of cost sharing? And we get in a little bit deeper to cost sharing. I think there's a big difference between having a $5,000 or a $10,000 deductible as opposed to the possibility of, say, an income-based sliding scale of on-the-spot co-payments, particularly those for things like emergency treatment, which has a long history of overutilization, or for those kinds of procedures that tend to be high cost, low value. And there are a number of other groups that are working on identifying those things, trying to find strategies to better contain them. And certainly I think cost sharing as part of the discussion makes some sense. Not to say that we believe necessarily that cost sharing should be instituted for each and every visit someone makes to a physician, for instance. But in some cases, as Professor Katz pointed out, trying to help guide utilization trends, helping to control costs, and helping to avoid unnecessary treatment are all reasons why, in maybe a broader perspective, we might say that some consideration could be given at a later time as to what exactly a cost sharing model should look like.
Shane, do you want to speak to that? You could say no, and I can call him.
I mean, thank you for the context. I think ultimately the question for the group is, so current state, what we're planning to do is to include a model that has current state cost sharing and show what those results are, and to have a version that doesn't have cost sharing and what we assume the impacts of those are. And if we need to have a different scenario or different assumptions, that's what we need to hear from the work group so that we can look at that.
I think what I'm hearing from Patrick, and sorry, Liz, I'll capture this and then I'll get a jump in. I think what I'm hearing from Patrick and perhaps others is that that for some work group members, cost sharing is not necessarily an absolute no, but whether it's really about how you structure it, and that there's some cost sharing that could really impact access and equity, but there might be others that could be structured in such a way that could have some benefits, like reducing low value care without impacting equity. Liz, I'm going to pass this over to you.
I was just going to say that I think this is a really important conversation, and one that if, what Shane is saying is that we would model with cost sharing, without cost sharing. It doesn't say specifically what the cost sharing would be on or for, and that would be something that a potential work group, implementation work group going forward would continue to deliberate on about where do they consider it appropriate, what is the latest research, et cetera, et cetera. It seems like it's a real implementation issue, but the model that they're going to share with us would show with and without.
Okay, Shaston has her hand up, and then Vicki, and then Dr. Weinberg. Shaston?
Oh. Can you hear me?
Yes, we can. Thank you.
Oh, okay. I think another thing that might be good to include in that is also the cost of delaying needed care that ties in real well, I think, with cost shares. That's something I think we should highlight as well.
Thank you. And folks have raised that point before. I'm not sure that we'll be able to have specific data on it. I'll look to our project team. I think that might be more around making sure that we highlight that as an potentially understood consequence of people not having access to care. Liz, do you want to correct anything I just said or add to that?
No, I think again, it's a really important thing to bring up and consider if and when there's implementation work groups specifically focused on looking at all the cost benefits of cost sharing. Okay,
I see. Sorry. Vicki, you're up next.
So I realize we're really focused on money, but I think it's important to shift our values a little bit and talk about care. So if people get the care they need, which is health equity, then I don't think we'll be seeing people use the ER. If people have access to primary care, a lot of times the reason people go to the ER is because they can't get a primary care physician, and usually that's because they have Medicaid, and primary care docs won't take the low payments from Medicaid. So we think if we remember that part of what we want to do is make sure that all Washingtonians have access to health care. Isn't that our goal? And so are we looking at, is there enough primary care physicians to do what we want to do? Are we going to have the right workforce? Are we thinking of those things too, or are we just looking at money? And I really think it's important for us to ground our values in what we're really trying to do and remember that as we move forward. And I don't want to see using financial penalties to punish people for being poor. Thank you.
So Vicki, to clarify, I want to make sure that I'm understanding correctly, that from your perspective, having a copay to discourage something that let's say a panel says is low value care is problematic because.
Absolutely.
Okay, I have that correct. Okay, good. Yeah.
And I'm also just saying that I think we just need to every once in a while refocus, because we get into this really focus on money. But I think the other piece is healthcare and access to health and improved health for all of the people in our state. I mean, that's one of our goals of the commission, is to improve the health status of all American Indians, Alaska Natives in Washington state. And so I just want us to be really thoughtful about that too.
Yeah, no, I appreciate that. And this work group has done quite a lot of work on both before you were able to join us and since then on articulating the range of issues that this work group values. Very much access and equity are at the top of those lists. I see Dr. Weinberg and then Dawn. So Dr. Weinberg.
I just want to state that if you want to get rid of unnecessary health care, eliminate advertising of doctors and procedures and drugs on TV. And that's what will do a lot more good than trying to jockey around with copays. Thanks.
And I think that can be something that can be covered with future implementation steps. I do want to move us on from the cost sharing discussion because I do think we've covered this pretty thoroughly, and I want to make sure we get to I know there were some concerns about some of the assumptions around the administrative cost savings, and Shane and Jared could really use your boots on the ground. I think I heard Shane say feedback. So I see Dawn and then Jane, and then I'm hoping we can move on to the other topics. Dawn? Oh, you're still muted, Dawn. I think you have to click on mute on your end.
I just wanted to bring up some points and kind of build on what Patrick had to say. As a small business owner and as somebody that's involved in neighborhood health, I kind of have my feet in both areas. And I have to say there's vast businesses that don't insure their employees. I'm thinking of restaurants, a lot of contractors, daycare operators. And the reason is they can't afford it, or there's a political mind block that stops them from accessing what they have in their mind as socialized medicine. And so they resist a lot of that. But I also have a lot of people that, because of my association with neighborhood health, that are working for small businesses, and a small business owner will call me about an employee that has got some serious medical problem, and all of a sudden they're uninsured and they want me to access coverage through neighborhood health for them somehow. And this is happening all the time. But the other real thing is we're really attuned to going to emergency rooms. I mean, it's really weird. We're probably one of the few countries that show up at an emergency room for a relatively minor thing that could be put off until Monday. But it's a philosophical thing that occurs. And one of the problems I have with option C is I sense a sense of you need something that's mandatory that makes sure that everybody's insured and some way to do it. And I worry about option C is it doesn't get past this block of why people don't get insured. And I'm not sure we even understand why a lot of people don't get insured. And I think the real reason is they're healthy, and buying an insurance policy or getting somehow insured is outside of their budget. They have daily budgets that have an account for healthcare, and one of the reasons is we let people get free healthcare, and wonder why it costs so much. So I'm not highbrow like the rest of the group. That's really, in my opinion, why we have a lot of uninsured is that we're just not in tune to getting them insured, and people aren't in tune to getting themselves insured.
So Donna, it sounds like you're raising maybe something that we would want to put in the next steps or implementation section of the report, which is maybe doing some, getting a better understanding of what are some of the barriers for people to getting insured, and also what are some of what are some of the things that lead people. I know we understand that some people go to emergency rooms because that's their only option given their coverage, but maybe we need a deeper understanding of why other people might go to the emergency room.
Even people with coverage end up in the emergency room when it's totally unnecessary. Sure. But I think we have to consider the self-inflicted barriers, though, not just the ones that society gives, but the ones that are self-inflicted. And that's a big hindrance of why the remaining people aren't insured right now or haven't sought out coverage.
Yeah, I think that's well put, using the phrase self-inflicted. Jane?
Yep, I guess the only thing that I would say is when we think about cost sharing, we think about it from two perspectives. Number one, to try to incentivize people to use more effective or less costly services. And number two, just to keep premiums down. And so on the question of cost sharing to incentivize people to use more effective services or whatever, just bringing into consideration the fact that as much as we all hate prior authorization and, you know, EMRs that tell doctors what to do, there are other ways to approach sort of directing folks into more appropriate utilization than having it cost more for them.
I think if I'm in project team, Nora, let me know if you see this differently, but I think what we have now is a good picture of the range of perspectives on cost sharing. And I don't hear any loud champions necessarily for cost sharing, but maybe more taking steps to find places where we can minimize low value care. I think that's my takeaway from this conversation. So again, I think we have an opportunity to document all of these perspectives in the report. Shaston, I see your hand up.
Can you hear me still?
Yes.
Oh, okay. I just have to comment on the emergency room access issue and why people go there. What I see in my daily work is that's because that's the one place you can be seen without paying first. It's very much tied to affordability and access to provider networks. You go to an urgent care or a primary care physician, before you get through that door to see the doctor, they're going to ask you to pay. And that is a big deterrent for people. Nobody wants to sit for hours in the ER, but that's the option people have.
Thank you, Shaston. I appreciate that perspective on what sends many people to the emergency room. I'd like to turn our discussion now to the administrative cost assumptions, specifically around cost savings in provider reimbursements. So we did hear from a few of you in response to the presentations from Optimus that you had some concerns about the assumptions made there. Shane or Jared, do you want to, is there anything you want to say to queue up this question other than what I've put out there?
I would just reiterate, so I gave some kind of like high level perspective on like the difference between first year savings and potential and out years. So just to re-queue that up. And then I would also note that as part of the discussion, like one of Jane's points, you know, that there are other ways to get at efficient utilization. Some of those are provider sided. And it just really highlights the point that how you implement and design the system is going to determine the administrative cost, because if you're using a provider-sided solution for the most effective utilization management, then your administrative costs on the provider side will be higher. So there are, I mean, it's a big, complicated system, and there are trade-offs. So I just point out, you know, try and keep these things in mind. If your like your view of utopian healthcare includes no cost sharing, but you recognize that we need utilization controls that might be more administratively burdensome on the provider side, then our assumption should reflect that. So just again, that context, and then we'd really appreciate any, you know, again, the boots on the ground feedback.
So I'll reiterate the question there, which is, does the work group agree with the current assumptions around, particularly given the context that Shane has provided, the additional context that Shane's provided, does the work group agree with the assumptions around administrative cost savings? Kelly?
I was just, actually, I'd like you to mute, sorry. Go ahead. Yeah, I got a barker.
Sorry, Kelly, we weren't able to hear what you said. If you want,
I just wanted to know what Shane's specific questions were. Did he have?
I think that the specific question is, do the work group members, given the context that Shane has provided to you, do the work group members agree with the assumptions around administrative cost savings? And what, you know, understanding that you're not actuaries, the question's really around, have you seen anything in your experience that suggests that there might be a different way of looking at this? So I think it was Aaron and then Dr. Tritko. Aaron?
Yeah, just to reiterate, Shane, I'm not sure if you said this or somebody else, is that, okay, if the limitation really for your work is you have to focus on year one, I can understand that, and I understand that capturing administrative savings in the first year is, I mean, the administrative savings that would likely be there in the first year would be low. So I get that. But I would sure want the report to talk about, you know, with your, from what you know and your expertise, what the, you know, out year potential is. Because you know, just because I think the evidence from other systems that are more simple on the financing end, that are less fragmented, is that the administrative burden on the provider side is much lower. And while I haven't seen a cause and effect analysis, I think the evidence is pretty compelling that there's a relationship between those two. So to the extent we defragment the financing, we will simplify the administration on the provider end. And I think I'd just like to see the report speak to that, even if the estimates, even if the data can't.
That makes sense. Thank you.
Okay, Dr. Tritko and then Vicki.
Yeah, I don't think there's been many areas in healthcare that have grown as much as administrative costs. And it does speak to our fragmented system and the multiple different methods of payment and the fact that incentives aren't aligned. If we wanted to reduce administrative costs, what you would do is listen to the hospitals, doctors, our associations, and implement all of the administrative simplification changes that we have suggested. Being that that's not likely to be done, I don't think we can assume that there's going to be much in the way of reduced administrative costs until we move past fee-for-service and get to more global payment. It's just going to take a few years. Thanks.
And I think I'm going to channel Nora here. Nora, tell me if I get this wrong, but so much of what we're discussing today is also in the details of the implementation and how we design this, or how future groups or portions of the legislature or portions of our state agencies design this to realize cost savings. So what we can communicate is the importance of defragmenting, for example, to Aaron's point, defragmenting the financing system to realize cost savings, but then the actual implementation details would be forthcoming. Is that accurate, Nora? Okay,
yes,
I see.
The devil's in the details as the key thing. I also just wanted to quickly note that our friends in Oregon have a legislatively mandated group that has been looking at setting a target for overall system-wide cost growth in healthcare. And recently it's been, in Oregon, it's been about 6.5%, and they have agreed to a target for the first 5 years of 3.4, I think. And then shrinking that down to 3% for the following 5 years. And to get to that, so this group isn't talking about what do different entities need to do to achieve that cost growth, but they are talking about how they track it and identify who's making it happen. So I just wanted to note there, kind of, because we've been having a more expansive conversation about different ways of getting at a revised system. This is an effort that's going on in Oregon and is tied to data collection, both on the cost side, but also quality and equity, so that entities aren't just, withholding care in order to get to that.
Thanks, Nora. Vicki, you're next, and then Dr. Weinberg, and then Ronnie, I'll come to you.
Well, I just wanted to add to Aaron's point, and then, Shane mentioned wanting some boots on the ground, real world experience. In our clinic at Jamestown, we started in 2000. We had one person doing referrals and two ladies doing billing. And now we have grown, and we went from 3 to 5 providers, and now we have 17. So now we have a whole billing company doing the billing and 5 people doing the referrals and authorizations and the records and all that. And we've gone to an electronic health record system, which is supposedly saving us time. So all of that extra cost could hopefully go away, because it used to be great. Thank you.
Would it be okay
Real
if I
boots
ask
on the ground. Thank you. Go ahead, Shane.
Could you help me understand, was that solely driven by the fragmentation in insurance, or was it attributable to growth in the size of the business as well?
Well, is Sue still on? No, part of it had to do with the implementation of managed care into the Indian health delivery system. And we've actually staved it off for as long as possible, but I did the contracting with the plans when we first started, and it was pretty straightforward. But then every year, you know, there's a different process for credentialing the providers, and then having to track at one point there was a universal referral form that was being worked on. Does anybody remember the cheetah, Jane? And then that was great and helped us keep our staff down for a while, but then that disappeared and it went to the insurance companies just have enough referral for the authorization and referral process, but especially managed care.
Let's see, Dr. Weinberg's up next, and then Ronnie, and then Bevan. Dr. Weinberg?
I wonder if we couldn't get some data from Taiwan. Taiwan in the mid 1990s went from a fragmented private insurance system to a national health system paid for by payroll taxes. I wonder if we could look at their administrative costs in the transition, and both from the provider point of view and from the system point of view. But we could get some information for them that would go beyond the first year. It's been in effect for 25 years now.
Okay, we'll make a note of that, Dr. Weinberg. Thank you. Ronnie?
And I think one of the things that is really difficult to measure is the administrative savings on the provider's side. There certainly is some data on the number of hours a week that a physician in a small office or a large organization spends on insurance and on changes that are required by different companies. As a pharmacist, I saw it daily, and it lengthened the time that people had to wait for prescriptions. Certainly, an insurance card is not the only answer. There are so many layers in between. Insurance companies are forced to use pharmacy benefit managers, and in supplies, there are other people that help the insurance company manage costs that it really adds onto the workload phenomenally. I saw rooms of people in the Harborview Medical Center pharmacy that did nothing but talk to one insurance company that, you know, referred to a, you know, someone that was hidden from view, but to the patient. And it is so frustrating. You know, it causes medical errors that providers end up having to deal with when someone is discharged from the hospital. It contributes to people walking out because they can't wait any longer. And it's that burden is difficult to measure, but I think it's something we need to acknowledge when we're looking at the administrative costs internally just to manage an improved system. I think we really need to respect what a doc in a small office goes through, what large groups, clinic and hospital groups are going through. It can be a phenomenal time-saving cost saving for them. And on the business end, if you don't have a human resource center that needs to be trained on how to teach people, if you don't have an CEO that has to spend their time negotiating with insurance companies as well as employees, that it would be phenomenal administrative costs that we need to address.
Thank you, Ronnie. It sounds like, go ahead, Shane.
I'm going to say thank you also. That was really great context.
Okay, let's see. We have Bevan and then Dr. Tritko, and then I'd like to dive into a question about your perspective on the benefits that were included in the modeling. So Bevan, you're here.
Thank you. So I also wanted to kind of bring into focus a little bit more the bargaining power that I think really is awarded to the state, that really can help drive down the drug costs that I think all of us are hearing is a really significant issue for a lot of individuals, which of course then also adds to the administrative costs, right? When you have your capital costs as a hospital, as an example, right? Like if you don't have to pay such high drug costs in general, then that adds to the administrative costs. And I also wanted to know, was anything included around legal costs that are incurred on hospitals, providers, et cetera, for people who are underinsured or uninsured, where they have to go through claims, where they have to go through a legal process to get reimbursed for their, for looking at a fee-for-service model. So I guess I'm wondering how many externalities are included, in the administrative savings when we start to think about all of the ripple effects that the bargaining power brings into focus.
Those are good points. Starting with pharmacy, so we have included purchasing power adjustments on pharmacy. I don't remember off the top of my head. I believe it was 5% as the high end in the first year. Something to keep in mind is the Medicaid eligible program or population, for example. They do get very steeply rebated drugs. It's in many states, it's 50% back-end rebate to reduce costs. So kind of looking at that global reduction, that 5% is actually even bigger than you might expect, because it's 5% on top of a subset of on the global population, which includes a subset that already gets pretty steep rebates. So I think that is factored in. The actual magnitude, I think that this is one area where the longer term savings is, again, potentially larger. And that's mainly because the state's going to be going into this with little utilization data for all of these people that weren't, like, you have the APCD that provides a lot of information, but there are huge gaps in terms of charity care, ERISA plans and whatnot. So when they have the utilization data, their ability to negotiate will be much better. But even in the first year, I think there's a lot of opportunity. So that's a really great point, and it's something that we've included in the model. In terms of some of the additional factors that contribute to administrative burden, we haven't gone that far down the rabbit hole in terms of looking at things like reduced legal costs and whatnot. I don't know. That's something we can potentially look at. I don't know what information is available, but it's the overall point that the fragmented system contributes to all sorts of different administrative burdens for all sorts of different actors is one that's well taken. So.
Yeah, and I think, as far as I know, the #1 leading reason for personal bankruptcy in the United States is still medical bills, right? So, what is the cost to society that's being incurred there, right? If we were to think about people filing for bankruptcy and then having to lose their house or whatever. And I get that this is like really weedy econ stuff, but like factoring that into the savings I think matters, right? And especially if we're talking about, 5 years out. So I just wanted to point that out.
Yeah.
Dr. Tritko, and then Aaron, and then I'd like to talk about benefits.
Well, quickly, Vicki reminded me that, you know, we do have a secure portal, at least for physicians in the state, called One Health Port, and that is huge for credentialing, and we should be using it more for claims, particularly for information requests. They should all be electronic. These are things that we've brought up repeatedly to the legislature and to the OIC. We have to make it simpler. We just have to do that. And it's not a matter as much of reducing costs as it has a profound effect upon physicians. What physicians want to do is take care of patients. We don't want to be sitting in front of computers all day long and being harassed by health plans to get paid. And we don't want our patients to have barriers to getting them the care that they need. So while it may not be an administrative cost savings that is substantial, it is something that we ought to do. And we have the mechanism in place in the state in One Health Port to do it. Thank you.
Thank you. Aaron?
Forgive me, Jamie, but something that Shane said, just I need to present a little levity to the discussion. So Shane, you were talking about the rebates that that Medicaid gets, and it just reminds me, there was a guy named Joe Hunt. Joe was the vice president of what was then known as Blue Cross of Washington, and he took an opportunity at every meeting I was ever in with him to say, when this question about cost containment and premium reductions came up, he always had an opportunity to say, markdown comes from markup. The rebates in Medicaid have never given me much solace, given that they're rebates from prices set by the pharmaceutical companies.
Understood. All right, so I'd like to move to talking a little bit about the benefits that were included. And I think Shane and Jared, correct me, it was dental, vision, and long-term care were all ones that were included in the modeling based on feedback received from the work group when we discussed in June. What, if any, thoughts do you have on these now? Do you continue to agree? Do some of you continue to agree with having those included in the model? Do others have a different perspective? I see Kelly, and then Dr. Kovar, and then Dr. Tritko. Kelly? Oh, let's try that again. Kelly, you're still muted.
I'd like to make sure that we are looking at robust mental and behavioral healthcare costs. And I don't understand why hearing is not included, at least as a dynamic option. And there was one more thing. Oh, and long-term care. What are we talking about exactly there? Are we talking about just what was just passed in the legislature last year, or is this some new big deal proposal that we want to tack on to our work? Because I really think that would kill our whole proposal if we had robust long-term care factored in. And plus, it's a lot more work for Shane and company to figure that out. So, yeah, that's my 2 cents on that.
Okay. Jared, I see you're unmuted. You wanna respond to Kelly's question?
Sure. I'll try to. There's a couple points in there. So I think inside the FAQ, I think the questions. There's some information provided related to this. The majority of healthcare services are already covered either fully or partially within the current system. Employer coverage, state employee coverage, Medicaid coverage. There may be certain limitations on some of the hearing benefit, for example, such as the hearing appliances. There lacks a level of detail to get down to the minutia needed, really, to, I guess, get to some of the elements that maybe you're asking about. But I think generally speaking, I think it's safe to say that hearing is certainly represented in the expenditures. And I think if there were some incremental policies to cover one type of hearing aid, and I apologize if I'm speaking out of place, I don't know much about hearing appliances, so forgive me. But that could be certainly focused on in some of the detailed work groups. The second question you asked about is related to mental health benefits. And I think, realistically, we're looking at the fact that mental health coverage is embedded in the underlying data that we're using. Again, there may be some elements that is not robustly available to us in terms of if there are any sort of limitations, say within the ERISA plan. We do know that the non-ERISA plans are subject to mental health parity, so there is some requirement that the same scope from a quantitative and qualitative basis are included for mental health coverage. So we think I think it represents, at least the modeling that we have represents mental health care coverage. I think, you know, maybe to the degree for certain treatments that might be covered, say, or focused on in Medicaid may not be something that's focused on, say, within commercial coverage. We just don't have that visibility into the actual detailed benefit for every single health plan that's represented in the data.
So my understanding is that the healthcare appliances, I don't know very much yet about either. I expect maybe that will happen one day. That's the most expensive thing for people. And I was looking around on PEB and SEB, and they have $700 deductibles for hearing aids, which that's a lot for somebody on a fixed income. So, and then the other point I want to make is we're getting a lot of feedback that the Medicare coverage for mental health care is notoriously lacking or not enough. So I'm just trying to gauge where we are in our proposal.
Yeah, so, well, related to hearing services, assuming that the appliances are subject to deductibles, coinsurance, et cetera, those would be covered in our out-of-pocket adjustments that we had made to more or less cover what is captured in the out-of-pocket costs. Mm-hmm. And then in terms of Medicare, since they're excluded from the model, I can't really speak to anything specific about Medicare because we have the Medicare population isolated. I have not. I can't answer any questions specifically.
Right. I'm just
related to Medicare.
The only reason I'm talking about those is just to try to understand what are we doing. Are we providing the level of Medicare, or are we assuming $700 copay for hearing devices like we do for SEB and PEB? I can't wrap my brain around what we're.
Sure. And I'm sorry, this probably is not going to be satisfying. We don't know the exact detail of the questions you asked around that. And I'm not trying to be obtuse. It's just we don't have the visibility into it. I mean, we have a lot of different healthcare plans, their limits, et cetera, represented in the data. So the out-of-pocket cost sharing would at least get you up to the point of what their coverage is. But in the mental health is going to be representative of the mental health substance abuse benefits that are covered currently under PEB, SEB, employer. But again, we have a little bit of a hole as it pertains to some of the ERISA plans, et cetera.
Right, okay.
Jamie, Jane can actually respond a little bit to the behavioral health question as well.
Oh, thank you. Okay, well, folks, I'm going to jump out of line here and go to Jane, and then I'll come back to the order of people who raise their hands. Jane?
Okay, so Kelly, to respond to your question, so I can definitely talk to you about commercial health plans that are fully insured in Washington and are, PEB and SEB. And then to a certain extent also about self-funded health plans. So our mental health parity statute in our state requires that health plans and short-term limited duration plans and student health plans offer mental health benefits, which includes substance use disorder. And then for self-funded, like big employer plans, if they cover any mental health services, they have to cover the scope of like inpatient and outpatient, and all of those plans are subject to mental health parity requirements, to the federal mental health parity statute. So what I can say is there has to be parity in the financial requirements, the cost sharing, the number of visits that are covered as between medical, surgical, and behavioral health. But that does not mean that we don't have big issues around access to behavioral health services in the state. And actually, my agency has been working for 2 years already on a project to really try to take a deep dive on behavioral health parity compliance among the fully insured health plans. Everybody agrees we have a shortage of providers, but there are also things that can be done to make providers more willing to participate in networks. And that's probably part of what some of the issue is with Medicare too, in terms of the challenges with access to care. We we got a lot of work to do, but at least we have federal and state law that sort of underpins what should be happening. So hopefully that's helpful.
I know it's a big
Thank you, Jane.
goal for the state, so that's exciting. Yeah, great.
Yeah. And
thank you, Jane.
There was one other question, thank you, Jane, around long-term care. And so I think some of the supplement to the long-term care benefit, we hadn't provided an estimate previously. It's a pretty large expenditure in what you are providing. So what we are going to be providing an estimate for the long-term care modeling, but I did want to point out that there is a long-term care trust that has been approved, and I believe it's going to be enacted in 2022 to provide long-term care benefit to folks that pay into it. And it's about a $33,000 a year benefit in 2019 dollars, so it should adjust over time. But that's just giving you some background. At a higher level, in a study that was done a while back, and this is also covered in the presentation related to long-term service supports. This was done by Health and Human Services, that there is a substantial number of people that may need long-term care coverage as they age from 65 on. And it breaks down some.
I agree, but it's like a different work group. It's like another, somebody else's job to figure that out, is how I personally feel. I feel like that's not,
It's certainly very expensive, and it's certainly much more complex because, you know, the other thing that I do want to mention for everybody is that long-term care service supports is a broad group of services. It's not simply just personal care, and it's not simply nursing home care, but we are talking about, you know, getting into intellectual disabilities, not just physical disabilities. So it's pretty broad to try to, you know, estimate. The estimate is going to be a wide range just for folks to understand.
So do we have to include that? I mean, I understand including the $33,000 per year for people who, I understand that because that's a lot.
Sure.
But beyond that, I would like to ask the work group if that is really what we want to do.
And Kelly, that's exactly what we're asking right now. It's now that you've seen the impacts on the costs and also the uncertainties there. And it sounds like you are raising questions about including that in your own mind. Dr. Kovar, Dr. Tritko, and then Shastin. Dr. Kovar?
I just want to make a couple of points related to the scope issue you're looking for. One is just to take a step back rather than just saying, well, hearing and long-term care and mental health. There's a lot of other services that are probably alluded into. I think the term was used was all necessary services. And I just sense the imminence of kicking the can down the road if we just move it forward that vaguely. You know, coming to mind are the services as broad as acupuncture, massage, naturopathy, chiropractic, etc. And in previous iterations of reform, these are constituencies that have stepped up and been very vocal, advocating for their needs to be included. So I think I recognize how difficult this is, but we should, I think at some point, there needs to be some kind of discussion, whether it's using evidence, which is really problematic in these other disciplines. But I think leaving it that simple is just leaving a big can of worms for the legislature to grapple with. The other one is specifically, I was thinking about this in the area of dental care. So currently, most people on this call probably have a dental benefit of some sort, and it's probably, I don't know, $1,000, $1,500, something like that, and then you're done, and then you're paying out of pocket. Well, but if you're poor, and you now, fortunately in the state, have a Medicaid benefit, you really get mostly what you need. You don't get high-end restorative services, but essentially a population that's lived in a life of poverty, perhaps chemical dependency, has horrendous, exponentially more dental challenges than probably anyone on this call. And you can't just put a small price tag on it. So potentially from an equity point of view, we don't want to set this up as a losing proposition for poor people because they need what they need. And if it's a whole mouth of extractions, that's what they need. You can't structure financially a program, a benefit that will cut them off at some point. because that would really be potentially a big losing proposition. We're fortunate enough to have assembled a reasonable safety net for dental care in the last number of years, which isn't certainly not adequate, but it was a step in the right direction. It depends on not cutting them off and providing adequate benefit if they're qualified for those services. So we should really keep that in mind. And I think you can extrapolate that kind of thinking to whether it's hearing or vision types of services. But it really affects the financial modeling where you draw that line. But I do think all of those are areas that we really need to keep equity first and foremost. So in my world, as a practicing primary care person in the safety net, you know, this notion, it's a horrendous thing that people spend down to Medicaid to be able to live in a nursing home, but at least they live in the nursing home. And it's a horrendous situation, but we don't want to set some kind of arbitrary level that's so low that it may not be, we may not be able to grapple with it this time around, but there really needs to be basic access for long-term care at some point.
Okay, so Dr. Kovar, I just want to make sure I'm clear on your point, which is not necessarily that we can get into the details of the specifics of what is provided with dental benefits or long-term care or hearing, but more that, especially with equity as a key value for us, that there needs to be enough there that it provides people with meaningful benefits and doesn't put them in horrendous health or other positions. Did I capture that accurately enough?
Yes, that defining a low level of benefit that seems to be kind of reasonable for people of means doesn't transfer in vulnerable populations.
Okay. So presumably that'll be work I think a future group does. Unfortunately, I think there's lots to build on from past work on that. I want to be really mindful of the time because we're getting close to the end here, and I still have a lot of people who have comments. So Dr. Tritko and then Shaston, and everyone keeps moving around on my screen here. Dr. Tritko.
I just want to quickly say that if we're going to include long-term care and the other high-ticket items in A and B, it doesn't necessarily mean, and I don't think we should, include it in C since we're just filling in the gaps. And I'm going to take it as a challenge to find the video of the senior citizens trying to roll Dan Rostenkowski's car over in the 80s when Medicare passed it. I think it would be informative. Some people may remember that, right, Sarah?
All right, up next is Shaston, followed by Representative Macri. And Jason, I've seen your hand pop up and down there, so I'll check in with you too. Shaston?
Yeah, I just wanted to point out again the cost containment need here, and the hearing aids is a great example. It's a lot of what kind of contracting you can have access to. I've seen working with government pricing on hearing aids, something that will cost you thousands of dollars to go to a private hearing aid company can be available at $450 through government contracting. Also, in small rural areas, a lot of these behavioral health providers and physical therapists, acupuncturists, they run small offices, and they might be one person there with maybe a part-time person to help them schedule appointments. And we have horrendous requirements through managed care and other insurance for people to access services. There's a lot of prior criteria that has to be met, prior authorization. So that very much links into the admin overhead of this. And same with long-term care, it needs to be simplified.
Shaston, I think you raised questions that speak to the equity, access, and administrative categories of your assessment criteria. So thank you for that. Representative Macri.
Thank you. This might be a nice segue to the last comment. And it takes us back to some earlier comments about the cost of care and how we build into this managing, understanding and managing those costs. This group has talked a lot about the complexity on the payer side, and we've heard a lot of challenges that providers have in managing the administration around multiple payers. I also, and I agree with all of that, and there's good data on that. I also want to highlight the growing complexity on the care delivery side and how that makes it much more difficult to really understand the expenses. Healthcare expenses have always been somewhat of a black box, but even more so now as we continue to see mergers and acquisitions and hospitals and clinics merging into larger health systems. And the two bills that I asked to be shared with the group try to get at this. Nora mentioned the Oregon Cost Transparency Board. We did pass a bill in 2020 here in Washington State to move in that same direction. So we do have a cost transparency board that is getting stood up right now in Washington State, which hopefully will give us more information in the years to come. I have been working with a number of stakeholders on this call as well on a hospital systems cost transparency policy to help us get better data on that. And the National State Health Policy Group just came out with some model legislation on that idea of health system cost transparency, appreciating the impact of that, and in particular some things that we can't ignore, which include that healthcare inflation is not equal across the system. We see healthcare costs going up at much faster rates in terms of drugs and in terms of hospital system care. So I think these are both relevant points that we have to also include as we move forward, because we're talking about, to me, it feels like we're talking, as we should, in sort of like what is the ideal services, but we can't ignore the current state of complexity, and that is not just on the payer side, it also is on the care delivery side.
Thank you, Representative Macri. Jason, I saw your hand pop up and down. Did you want to jump in at all? Oh, you got it.
Thank you. I just wanted to, say my appreciation for everyone being able to refocus on equity. It's an extremely important topic, and not just topic, it's people's lives. And I really appreciate everyone refocusing on that. Second, I appreciate the opportunity to talk directly to the actuaries. This is something that not very many people get to do, and being able to do that and talk about the assumptions is really important and helpful for all of us to understand what we're projecting. I did have I had a lot of other questions, but everyone else had some really good questions that answered a lot of my questions. But one of my questions was around the utilization changes that we're going to potentially experience by moving to universal health care, things around what Dr. Kovar was talking about with dental. We have some Medicaid program, which is what I'm most familiar with. We have some serious need around dental care, and especially around adults, and the opportunity for them to have real access through better rates could substantially change our utilization cost estimates. And I'm just wondering if not just dental, but other things like hearing and others, how is that addressed in our actuarial study?
In terms of the dental?
Thanks.
Oh, sorry.
No, you're good.
Dental would be a good example, but I mean, we could talk about other things as well, such as hearing aids for adults, the differences between cochlear implants and other types of aids. I mean, normalizing from the Medicaid population, Medicare population, and the private pay populations, because they all have different characteristics of what they allow. So
yeah,
how do we handle that?
And that was, so that dental is straightforward. And I think we try to provide some of the additional deep dive detail, at least in the follow-up materials, but essentially we were able to look directly into dental, as it is a category that is prominently reported, particularly in NHE. So we could see what Medicaid paid, we could see what Medicare paid, we could see what out-of-pocket cost sharing was, employer, et cetera. So we, more or less, the way we looked at it, the estimate that we came back with is we modeled what a standard benefit across all populations would look like. And that's what the cost estimate is actually represented in the slide. So it's existing dental costs plus these amounts. And so in your example, if you had a Medicaid adult, what that means is that grows the benefit availability to those individuals that currently have some limitations in terms of what services are covered under Medicaid, to answer your question.
All right,
I was actually
it's
really helpful. Thank you.
Sorry.
Sure.
No.
Thanks, Jason. I was just going to send a chat to all of you, but I'll just say it out loud. We are running short on time, and I do need to reserve a few minutes toward the end to walk you through next steps. So I'm going to take Vicky's. Vicky gets the last word here, and then actually, Vicky, I lied. You get the second to last word. Jared has a clarifying question that he's going to jump into after you talk. But I'm going to take Vicky, then Jared, and then I'm going to run through next steps. So Vicki, go for it.
Well, I just wanted to add that from my experience working in the Indian healthcare delivery system and Shaston's as well, we probably have a lot of information that I didn't think that we have shared appropriately. For the dental, does everybody know what a dental health aid therapist is? And implementation of these other level providers are really important to keep the cost down in some of these really expensive care. And there's, for the Indian healthcare delivery system, we're trying to implement behavioral health aides and community health aides, behavioral health aides, to do some of the crisis care, because our providers are so busy with finding beds and doing all that stuff. We need a provider that does that level stuff, so that the mental health or the dentist can be working at the top of their skill level. Also have a lot of information, and Shaston alluded to it, about government purchasing and how that can impact your program. So I wouldn't mind talking to Shane and Jason, no, Jared about that. Sorry.
Everybody does it. You're totally fine.
Well, you blipped off the screen for a second. Sorry. So that's what I wanted to share.
Okay, so Optimus, you have a resource in Vicki to share some of her experiences on that. Thank you. Jared, you want to quickly just run through the clarifying question from Patrick on long-term care, and then we'll wrap it up?
Yeah, there was just a clarifying question about what that $36,000 benefit that I was alluding to is. It's a $36,500 lifetime benefit in 2019 dollars. So it's a lifetime benefit that can be combined with private pay, et cetera. So it's not an annual benefit. Hopefully that answered clarified my point I was trying to make there.
Thanks, Jared. All right, I am pleased as ever with the depth of discussion we had today. I think this is exactly what we needed to clarify your perspectives. And I also just really appreciate all of the thinking and, to use Kelly's word, marinating in the information that all of you did, and to come up with your perspectives today. I know there's probably going to be more thinking and more realizations that you're going to have between now and October 29th. If you do have more questions that come up about the actuarial analyses, please do continue to send those in, and we'll respond to those and share them as we go. We have, I think, another one that we're going to be posting, as Liz mentioned earlier. We're going to be posting shortly another update to those. We did not, as you know, get to our goals discussion today. So the good news is I hope that all of you recognized those when you saw the straw dog that Nora presented to you. They should be really reflecting all of the work that we've done to date and the range of values that you've articulated that are important to you. So what we're going to ask of you is to provide us with written feedback. You're going to have some homework here, written feedback on those goals and objectives. And we're going to look at what you send in and see what we can do to have some deliberation on the areas where there needs to be some deliberation to clarify your perspective. Similarly, I know I did receive feedback from some of you on the outline. I had promised you that we would be talking about your feedback on the outline today, so maybe some of you didn't send me written feedback because you thought we'd be discussing it today. So I will extend the deadline on that. I'll send that back out to you and have you take a look and let me know. What we're looking for here is not necessarily wordsmithing, but more like, did we get everything in there and is it in an order that makes sense to you? So if you could take a look at both those, what I'll do is I will send you probably tomorrow morning, a follow-up email that has both the goals, the draft goals that Nora put together, and the outline with some deadlines for when I'd like to hear feedback from you. Again, as I mentioned, I will be reaching out to a number of you to have some one-on-one conversations, and as I committed, I'll work on how I can share and surface those perspectives so that we can deliberate on them and they don't happen in a black box. Liz, Nora, Betsy, did I miss any action items here that we need to cover? No, we're good? Okay. Thank you everyone for yet another really good conversation. I hope you all have a wonderful evening. Don't forget, we're all getting back together in 3 weeks, October 29th. And that's going to be another big day. We're going to do a lot of wrestling. So again, thank you for all of your time, for your great thoughts, for your productive, provocative provocation, your provocative productivity. We'll see you soon, and look out for an email from me tomorrow. Take care, everyone.
Thank you, Jamie. Thanks, everybody.